جلسة بعنوان Innovations in Cardiovascular Pharmacology New Drug Development، والتي تتناول أحدث الابتكارات في علاج أمراض القلب والأوعية الدموية، مع التركيز على الأدوية الحديثة التي تم تطويرها مؤخراً ودورها في تحسين حياة المرضى. ويدير هذه الجلسة استشاري في علاجيات القلب في مدينة الملك عبد العزيز الطبية، يمتلك خبرة عميقة في علم الأدوية، وشارك في العديد من الأبحاث الرائدة في المجال. رحبوا معي بالدكتور حليم شمسان.
Assalamu alaikum. Good morning, everybody. It is my pleasure to moderate this session. It is a very important session in this excellent meeting. We started yesterday night with a very successful session, and I hope this will be more successful, inshallah. Our topics considering the cardiovascular pharmaceutical innovations. And we have 5 speakers, excellent speakers with experience in clinical pharmacology and training programs in leading center in Saudi Arabia. We will start first speaker, our guest speaker, Dr. Turki Asiri. He is a consultant clinical pharmacist, cardiology in Prince Sultan Cardiac Center. He is a director of the residency program. He is interested in dyslipidemia. He will give a talk regarding future of lipid management, exploring novel therapeutic of dyslipidemia. Welcome, Dr. Turki.
عليكم ورحمة الله وبركاته. صباح الخير for dyslipidemia. Start with the this is my disclosure. Okay, this is my objectives. I will try to take less than 20 minutes because of the delay. I will talk about local and global burden of the disease, current management strategies, unmet needs and limitation of current therapy, and emerging therapies and new innovative approaches in the treatment of dyslipidemia. Cardiovascular disease, as we know, are the leading cause of death globally, and taking about 18 million lives per year. Evidence indicating that higher LDL, particularly with the prolonged exposure of this high level associated with increased risk of atherosclerotic cardiovascular disease. Dyslipidemia is one of the most prevalent ASCVD risk factors in Saudi Arabia, and the management of dyslipidemia is moving beyond just statins to a new area of novel, highly targeted and long-acting therapies. I will start with facts for the dyslipidemia management that's supported by evidence. Elevated cholesterol level are linked to the increased risk of major adverse cardiovascular events and that was supported by a lot of evidence, starting by Birmingham study showing that was published in 1961, very early, showing that there is correlation between the high cholesterol and the cardiovascular disease. Total cholesterol more than 244 associated with threefold risk of incidence of coronary heart disease. And also, Interheart study, which was biggest case control study, showing that among the modifiable risk factors associated with myocardial infarction, high lipid is one of them. In Saudi Arabia, cardiovascular disease is the leading cause of mortality with about 37% of total death. And multiple factors contributed to increased cardiovascular risk in Saudi Arabia, also in other studies showing that dyslipidemia came with 54% in our population. Also, our patients, according to local studies and compared to the international studies, our patients, they came with 10 years younger than other population. As you can see in the Gulf region, we are about 58 years as compared to Europe and US and Australia. So the other facts with lipid-lowering therapy, lowering LDL by 1 millimole per liter lead to reduction of MACE, the major adverse cardiovascular events, by about 20 or more than 20%. And that was supported by a lot of studies. This is one of the landmark studies, CTT collaboration, meta-analysis of about 170,000 patients, showing that reduction with the statin therapy reduction, 1 millimole per liter, leading to reduction of MACE by about 22%. And that's also applicable for non-statin therapy. A lot of studies also combining the statin and non-statin therapy and showing the same results. On the left side, with the statin therapy, 1 millimole per liter, reducing MACE by about 23%. And on the right side, reducing LDL by 1 millimole per liter, reducing MACE by 25% with non-statin therapy. So it is really LDL reduction. The other facts now supported by evidence, very low LDL is better and doesn't lead to significant adverse events. And as you can see in the studies that conducted lately and the recent studies, they are aiming a very low LDL, and even they started with a low baseline LDL about 90s. And all of that study showing a great benefit in cardiovascular reduction. Also, this is nice, a study, meta-analysis for more than 300,000 patients. They compare patients with genetic polymorphism as compared to patients who started lately LDL lowering therapy with a statin. You can see the blue mark, I can see if the pointer is working. Maybe because of the light. So the reduction of MACE is greatly increased with patients with polymorphism. You can see about threefold greater reduction of coronary artery disease on patients who have genetic polymorphism and very low LDL for a long time as compared to patients on statin therapy. So that means longer and persistent longer reduction will correlate with more reduction of cardiovascular events. This is subgroup analysis of prior trials. Also, they focus on patients with very low LDL, less than 0.5, and they make subgroup analysis, and they found that 31 reduction of MACE with patient with LDL less than 0.26. And that was even more than the outcome of the original study that showed 15% reduction. So whenever we go down, we have more reduction of MACE. And the fourth fact, most patients are not on their target LDL. Unfortunately, this is also supported by evidence. This is a nice study conducted by Dr. Mirfat and our colleagues also in Saudi Arabia. They explore most of the studies conducted in our regions, and they found that from 28 to 23% only in our population, they are achieving the target, indicating that about 65% of our patients, they are not on target LDL. And globally, by Da Vinci study, this is also a big study, about 400,000 patients or 500,000 patients, also indicating that 18% of patients only achieved the LDL reduction for the secondary prevention. Another study showing that 50% of patients discontinue their statins within less than 2 years, and the most common reason because of the side effects leading to discontinuation of those medications. So it is even global problem. Because of the time, so quickly I will just talk about the current managements and current guidelines recommendation. We'll start with the American Heart Association 2018 guidelines. They put a threshold of more than 70 milligram per deciliter to start non-statin therapy, and after giving ezetimibe in very high-risk patients. For European guideline that came 1 year after, also they make more specific goals and multiple categories of patients. For the very high-risk patients, they put a target of less than 55 milligram per deciliters. And also patients who have second events within 2 years, they also put a target less than 40 milligram per deciliter with class 2B recommendation. The Saudi guidelines came after that in 2022, and they adopted the European guideline, and they put a category named extremely high-risk patients who had multiple events with targeting LDL less than 40 milligram per deciliter. To bridge the gap between the guidelines, the American College of Cardiology 2022 expert decision pathway also put a suggested pathway for starting non-statin therapy, and they put the threshold of less than 55 or more than 55 milligram per deciliter to start non-statin therapy, starting with monoclonal antibody and ezetimibe, depending on the percentage needed for the reduction, and if it was those medication, is there any side effects or patient unable to inject, they consider going to the second group of medication, bempedoic acid and inclisiran, and that was before the outcome trial of bempedoic acid. 2023 guidelines for chronic coronary disease guidelines in American, they put the almost the same for the previous guideline. For considering B69 inhibitors, monoclonal antibody, ezetimibe, if the patient didn't achieve the goal, and if patients, if that was insufficient, or patients not tolerating the medications, to consider inclisiran or bempedoic acid with class 2B recommendation. Lately, this year, the acute coronary syndrome American guideline 2025 also made some changes in the targets and make class 2 recommendation for a patient with LDL still more than 55 to start non-statin therapy. Dr. Faisal will talk in details on this guideline. So summary for the latest landmark outcomes trial in dyslipidemia, we have 4 trials with outcomes results. I'll start by Fourier trial for the evolocumab published in 2017. Evolocumab reduced 5-point composite of MACE by about 15%, and LDL reduction, main LDL reduction 59% over 2.2 year. Odyssey outcome trials published in 2018 for alurcumab, this also monoclonal antibody in ASCVD patients, reduced the 4-point composite of MACE by 15% and mean reduction of LDL by 5.4% over 2.8 years. Reduced a trial that was specifically for triglyceride, reducing the 5-point composite of MACE by about 25%, reducing triglyceride 18.3% over about 5 years. Clear outcome trials published in 2023, 70% of those in the patient of the trial with ASCVD, it reduced 4-point MACE with 13% and reducing LDL about 21% over 3.4 years. And this table showing the impact of the reduction of LDL with multiple agents. As we know, statin, high intensity, reducing LDL by about or more than 50%. Adding ezetimibe, adding about 15%, so it will be like 65%. And giving triple therapy, including B69 inhibitor, ezetimibe, and statin, we can achieve 85% reduction. It is varied from patient to patient. In our practice, some of patients even achieved 95% reduction, and others less than 50% reduction. So this is estimated. We'll go to the most important slide in this presentation, the unmet needs and gaps of current therapy. The first unmet need is the inadequate LDL target attainment. As I mentioned in the slides, that most of the patients, they are not achieving the target. So it's important to intensify lipid-lowering therapy and to achieve the target for the benefit of the reduction of cardiovascular disease, as I mentioned in the previous slides. And the poor adherence and statin intolerance also, it is an important factor, and we need really tools to improve the adherence and the monitoring of those medications. And the residual risk is one of the important areas now under studies, and we have a lot of factors that related to residual risk despite the LDL reduction. One of them is elevated lipoprotein A. Studies showing this particle associated with increased ASCVD risk. And until now, there is no approved medication, but there is ongoing studies and promising trials. I'll talk about it in the next slide about medication reducing lipoprotein A. Also, the residual triglyceride-rich lipoprotein risk, as shown in reduced trial, reducing triglyceride may have a benefit. We are waiting for multiple trials also to validate the results of reduced trial to aim for reduction of the triglyceride as one of the residual risk. Other residual risk, ApoB, non-HDL, metabolics like diabetes, obesity, thrombotic like the platelet aggregation or activation, and endothelial dysfunction, inflammation like high C-reactive protein. All of this under studies now to discover the relation with the cardiovascular disease. Familial hypercholesterolemia also, it is a missing area, underdiagnosed, undertreated. Dr. Ali Tbinawi بيتكلم عنها إن شاء الله. He will talk about it in details. For accessibility and cost barriers, also this is important area, need to be focused on. B69 inhibitors, novel therapy, but not always affordable, not always available to the patients. Accessibility to the healthcare system is important. We'll talk about inclisiran, for example. It's a novel medication. It needs good access to hospital, so patients can come anytime to get the injection because it should be injected at hospital. So the accessibility is important factor to be identified. Clinical guidelines gaps, especially variation LDL target recommendation. Hopefully with the new released guideline, Dyslipidemia, we will have a good unifying in the LDL targets, so to unify the practice. No clear guidance on lipoprotein risk and target in the guidelines. Lack of universal approach for residual inflammatory risk. So what about the emerging therapies and new innovative approach? Bempedoic acid, after release of clear outcome trials for statin intolerance, it is the first medication studied with clinical outcome in statin intolerant patients. Inclisiran as a novel medication, small interfering RNA. Dr. Naif will talk about it in details. It's having more prolonged LDL lowering efficacy than with monoclonal antibodies and reducing LDL by 50% and with acceptable adverse events, mild injection reaction, and larger scale outcome trials ongoing. And this is also summary for all the studies conducted for the inclisiran. We are waiting for the last two trials, Orion 4 and Victorian 2B. It will be released and completed expected on 2026 and 2027. Evanocumab also, it is one of the novel medication targeting the anti-angiopoietin-like protein inhibitors and giving as intravenous infusion for homozygous hypercholesterolemia. Also, Dr. Ali will talk about it in details. The other agents, I will talk about it now. For the lipoprotein targeting agents, we have three molecules. All of them pass phase 2 trials with a great reduction of lipoprotein A. Bilacarzin by Novartis, it is antisense oligonucleotide targeting ApoA mRNA. The phase 2 trial showing that this medication reducing lipoprotein A by 80%, and it's given monthly subcutaneously. Olpasiran by Amgen, it is small interfering RNA given every 3 months, reducing lipoprotein by 95% as per phase 2 trials. And there is ongoing ongoing phase 3 trials expected to be completed next year. For Inclisiran, it is also a novel small interfering RNA, reducing LDL reducing lipoprotein A 94%, and the results of phase 2 trial just released in the previous ACC 2025 conference, and the outcome trial started and will be end on 2029. For emerging triglyceride lowering agents, we have already the icosapent. I talk about it. Reduce the trial. There is outcome trial. There are now 2 medications approved in USA. There is 1 medication, olezarsen, approved last year as response to balance trial. Olezarsen reducing triglyceride by 75% and reducing the incidence of acute pancreatitis. No outcome trial conducted in this medication. And it is antisense oligonucleotide inhibitor targeting ApoC3. Folinisonsern, this medication approved by Europe and EMA, reducing triglyceride by about 70%, have some side effects like thrombocytopenia, and as a result of approach trial. The other medication is still under phase 1 and phase 2 trials. Going to the gene editing, the interesting area in the dyslipidemia, gene editing using CRISPR-Cas9 system now is ongoing. This is groundbreak of therapeutic approach managing dyslipidemia. It provides potentially permanent solution and by directly altering DNA sequence associated with lipid metabolism. They are targeting 2 genes, the B69 gene and angiopoietin-like peptide gene. Currently, the Verve therapeutic company, they have 2 studies ongoing, phase 1B. For Verve 101, 102 just released with reduction of 53 to 69% of LDL with only 1 single administration, as announced last week from the company. So we're waiting for phase 2 and phase 3, and this will take a long time to be initiated. But this is promising medication. It will be given once per life, and it will be, if it is successful, will be a complete treatment and solution of dyslipidemia. So at the end, this is the evolution of lipid-lowering therapy, starting by statin, adding oral combination therapy, adding monoclonal antibodies, antisense oligonucleotides, small interfering RNA, and vaccination. For vaccination, we have 2 vaccines now in phase 1 trials targeting B69, and mostly, if it is successful, it will be given once per year. And at the end, the gene editing. Thank you for listening, and sorry for taking more time.
Thank you, Dr. Turki, for this comprehensive and excellent review. We will keep the question to the end of the session. Our next speaker is Dr. Faisal Al-Garni. He is a consultant clinical pharmacist from Security Force Hospital in Riyadh. He is also board certified in clinical pharmacology, and he is director of residency program in Security Force Hospital. His talk will be about recent update from the current ACC meeting 2025. Welcome, Doctor.
Assalamu alaikum. Good morning, everyone. Thank you, Dr. Halim, for introducing me. It's been a pleasure to be here in Ha'il and to visit the city for my first time. I really enjoyed my stay here. Thank you, Dr. Faris, Dr. Hatem, and the rest of the organizing and the scientific committee for the invitation. Today, I'm going to be talking, inshallah, about in light of acute coronary syndrome guidelines. I will focus on the updates on the acute coronary syndrome. This is a new guideline that has been recently published, so I hope you are going to enjoy it. So this is my disclosure. I have no financial interest, affiliation, or arrangement that could constitute a conflict of interest. So this is the outline. At the beginning, we are going to have an introduction about the acute coronary syndrome, its types, and we will go over the history of the guidelines. Then we will talk about the antiplatelet therapy, the types of the antiplatelet, and we will see a variety of recommendations regarding the antiplatelet therapy. And then we will be talking about the lipid management in the context of the acute coronary syndrome. So as an introduction, acute coronary syndrome includes unstable angina and the two types of the MI, STEMI and non-STEMI, or resulting from reduced blood flow to the coronaries due to blood rupture or thrombosis. So the guideline that we have now is the first full combined acute coronary syndrome guideline. And the last guideline that we had before this one, it was published in 2014. So we have been waiting for almost 10 years to have this full combined acute coronary syndrome guideline. So it's going to be a very important guideline to be discussed. So the first part of the guideline that we are going to be talking about is the antiplatelet therapy. The antiplatelet therapy is a cornerstone, as we know, in the management of acute coronary syndrome, aiming to prevent thrombus formation and to reduce the risk of stent thrombosis. We will go back to the time before 2001. Aspirin alone was used as a standard of care in the management of acute coronary syndrome. This has changed with a landmark trial called ACURE study that was published in 2001. It showed that the dual antiplatelet therapy, aspirin plus clopidogrel, the only P2Y12 inhibitor that was approved at that time, significantly reduced major cardiovascular event in the management of acute coronary syndrome. Since that time, dual therapy has become a standard approach in the management of acute coronary syndrome, whether in the acute phase or for the secondary prevention. So in 2007, another P2Y12 inhibitor came to the market, which is prasugrel. Prasugrel has been studied against the standard of care, which is clopidogrel, the study called TRITOIN trial. The study showed that the use of prasugrel was associated with significant reduction of the primary endpoint, which is the cardiovascular, which is the non-fatal MI, non-fatal stroke, or cardiovascular causes, compared to clopidogrel. Another P2Y12 inhibitor came to the market in 2009. It was the ticagrelor. Ticagrelor also was compared against the standard of care, which is clopidogrel, and the study called a plateau trial. The study also showed a significant reduction for the major cardiovascular event, the vascular causes of the MI, strokes, or peripheral vascular disease, compared to the clopidogrel. Given all the previous evidence regarding the ticagrelor and the prasugrel, the American College of Cardiology released recommendations in 2016. The recommendation said at that time that as a class 1 recommendation, you could use either prasugrel, you could use ticagrelor, or even you could use clopidogrel. All of them were recommended as class 1 recommendation. There was also a recommendation as a class 2A recommendation, which means it's reasonable to give the preference to the prasugrel and ticagrelor over the clopidogrel. So it was recommended only as class 2A recommendation. So despite all the strong evidence that we have seen with the prasugrel and the ticagrelor, the guideline was hesitant to provide stronger recommendation to the ticagrelor and to the prasugrel. And in my opinion, that was because the long experience that they had with the clopidogrel, or we had with the clopidogrel, and the limited real-world data about the prasugrel and ticagrelor at that time. Now, in 2025, we have new recommendations about the antiplatelet. In all the settings of the acute coronary syndrome,
ticagrelor and prasugrel are preferred over the clopidogrel in all the settings of the acute coronary syndrome. So, and the use of clopidogrel should be limited to the situation when we don't have the ticagrelor and prasugrel or they are contraindicated. So this is a new recommendation, and we need to know there is a missing slide. However, there are several studies that showed that has been associated with significant reduction of the it has studied two outcomes, the efficacy and the safety outcomes. The efficacy outcome that they wanted to prove that ticagrelor alone as a this is a recommendation. So why did the guideline, as we can see here, the guideline diminished the role of clopidogrel, and they gave the preference to the ticagrelor and clopidogrel. So this is due to the limitation of the clopidogrel. So the limitations of clopidogrel, we have inferior ischemic outcomes compared to the clopidogrel alone, as we have seen in the trials. Also due to the modest related inhibition of the clopidogrel, also due to its delayed onset of action and the issues with and the concerns with the pharmacodynamic variability of the clopidogrel. So this is a recommendation that I would like to highlight in this guideline, that previously one of the prasugrel limitation, that if you have patient on prasugrel and you want and he will go for an urgent CABG, we didn't have recommendation to guide us regarding when to discontinue prasugrel. Now in this guideline we have a clear recommendation that after 24 hours you could discontinue the prasugrel and you could take the patient safely to the CABG, similar to the recommendation of the ticagrelor and also the prasugrel. So what if you have patient who is at high risk for bleeding, or you are afraid of the bleeding and you want to find a way to minimize the risk of bleeding? What could you do? In 2016 we had the recommendation that after the use of the dual antiplatelet therapy for 6 months, you could discontinue the aspirin or clopidogrel and continue single antiplatelet. So either aspirin or clopidogrel. However, this recommendation was not strongly supported by the guideline. It was only recommended as class 2B recommendation. In fact, there was evidence showed that when you use aspirin alone or clopidogrel alone in this settings, or in patient who has recent acute coronary syndrome, this could be relatively unsafe. So we didn't have a lot of options. Now in 2025 we have a solution for this. If you have a patient you would like to minimize the risk of bleeding, so you could use ticagrelor and aspirin for 1 month. Then after 1 month you could discontinue the aspirin and you could keep the patient on ticagrelor alone as a monotherapy. So this is a new recommendation, and we need to know the evidence behind it. So there are several studies have compared the two approaches, ticagrelor alone after 1 month versus the standard duration, which is 1 year of dual antiplatelet therapy. So they studied the safety outcomes and the efficacy outcomes. The efficacy outcome, they wanted to prove that ticagrelor alone was not inferior or non-inferior to the dual antiplatelet therapy in the term of the cardiovascular events. The safety outcomes, they wanted to prove that ticagrelor alone will be associated with lower risk of bleeding compared to the dual antiplatelet therapy. All of these trials met their outcomes, the safety outcomes and also the efficacy outcomes. However, each one of them has certain limitations. For example, the Twilight trial, they excluded the STEMI patient, which is the high-risk patient. Also, 60% of the patients were having stable and unstable angina. We have also the ultimate DAPT study. It conducted predominantly on Chinese population, which can be a limitation, and the percentage of unstable angina was 40%, which is relatively high. Then we have the TICO study. it was empowered to detect the differences in the ischemic events. And lastly, you have the TBAS study, which is conducted mainly on Korean population. So the guideline didn't consider this limitation as a defect in the standard of the ticagrelor as a monotherapy, which is understandable because several studies met the expected outcomes, okay, which means that there is reliable evidence. So now you have a recommendation. What you could do is you could personalize your option. For example, you have patient with the recent MI, recent STEMI, the initial diagnosis was a STEMI, the patient has left main disease, recurrent MI, multiple stents. So you are not going to be convinced to keep the patient on single antiplatelet. While if you have a patient who is at high risk for bleeding, then you have this option and you could go with the ticagrelor as a monotherapy. There is another approach that you could use to minimize the risk of bleeding, which is you could start initially with aspirin plus ticagrelor or aspirin plus prasugrel, and after 1 month you could do the escalation. You could shift to aspirin plus clopidogrel. However, this approach is not strongly recommended by the guideline, and it's only recommended as class 2B recommendation due to lack of supported evidence. Also, this is a recommendation regarding the use of the area of the triple therapy. There is nothing new, the same what we do in the practice. We try to limit the duration of the triple therapy to maximum of 1 month. And we should always balance the risk of the bleeding versus the risk of the thromboembotic event. And whatever the situation, we shouldn't exceed 1 month of the triple therapy. So how about the glycoprotein inhibitor, 2B3A inhibitors? The last recommendation that we have about the glycoprotein was in the STEMI guideline that was published in 2013. Since that time, the role of the glycoprotein inhibitor gradually diminished in the practice. And now we have this recommendation, which is class 2A recommendation. We could still use the glycoprotein inhibitor. However, in selected cases, patient will undergoing BCI with large thrombus burden or no flow or reflow. So as we saw that there is a limited role for the glycoprotein inhibitor, and this is mainly due to the adverse effect of the glycoprotein inhibitor, especially the thrombocytopenia, which can be significant. Also because these studies, these agents were studied before the area of the modern therapy, the ticagrelor and prasugrel, and we don't know, we have limited data about combining the ticagrelor or prasugrel with the glycoprotein inhibitor. So now we will explore the recommendations regarding the lipid management in the context of the acute coronary syndrome. Lipid management is a key component in the treatment of acute coronary syndrome. Lowering LDL cholesterol helps stabilize the stabilize the atherosclerotic plaques, reduce inflammation, and prevent future cardiovascular events. Clinical trials have shown that early and intensive statin therapy would help a lot to reduce the risk of recurrent MI, strokes, or and death as well. So the management of the LDL and the reduction of the LDL in the context of the acute coronary syndrome was strongly supported starting in early 2000s. The first recommendation that we are going to see here, if you have a patient with acute coronary syndrome and if he wasn't previously on statin or he was on suboptimal doses of statin, so what you need to do is you need to start high-intensity statin. You need to start with a high-intensity statin. So do we need to be aggressive and to start with dual lipid-lowering medication? What do you think? Well, the guideline, it's recommended only as class 2B recommendation by the guideline. So the class 1 recommendation is to start statin alone. Class 2B recommendation means it's a weak recommendation. It's not strongly supported by the guideline to start with the lipid to start with another lipid-lowering medication in addition to statin. And there are absence of strong evidence to support this approach. However, we could reserve this recommendation for a patient who is really at high risk of having thromboembolic events. And when you want to add another lipid-lowering medication, your only option would be to add ezetimibe in addition to statin. So do we have any role for PCSK9 inhibitor? In this case, the answer is no. I know this is a common in the practice. However, this practice is not supported by the evidence. It's not supported by the guideline. The guideline says that start statin in certain cases, add ezetimibe to statin. PCSK9 inhibitor has no any role at the beginning of the therapy. So after that, after you start your statin, your goal would be to reduce the LDL to be less than 70 milligram per deciliter. So this is a class 1 recommendation. If you want to reduce the LDL further to be less than 55 milligram per deciliter, it's going to be reasonable, and you could do it for a patient who is at high risk patient. And this is recommended as a class 2A recommendation, which is reasonable, but it's not strongly recommended as class 1 recommendation. So if you want to add another lipid-lowering medication to reduce the LDL further, what could be the options? Actually, the guideline didn't talk about this area. However, this is a recommendation. I took it from the lipid consensus that was published in 2022 by the American College of Cardiology. It says that if you have a high-risk patient and you want to reduce the LDL by more than 25%, then you could go with the PCSK9 inhibitors. If you are close from the target, or you have a recent ACS, or the patient doesn't prefer to take injections, or the cost is a consideration, then you could go with the ezetimibe. One of the things that I like about this guideline that they came up with a recommendation regarding the statin intolerance. So when you have a patient who has statin intolerance, then you could go directly and approach the non-statin lipid-lowering therapies. So what is your definition for the statin intolerance? The statin intolerance, to label the patient as having statin intolerance, you should try minimum of 2 statin, including one of them should be tried at the lowest approved dose of statin. That's all I have. Thank you for listening, and I would be happy to receive your question, inshallah, in the panel discussion. Thank you so much.
Thank you, Dr. Faisal, for sharing these recent updates from ACC and guidelines. Although there is some points need to be clarified maybe in the question session. Our next speaker is one of the eminent clinical pharmacists in Saudi Arabia, Dr. Fakhr Al-Ayyubi. She is the staff of King Saudi University, and she is active researcher, and she is running a lot of projects, including lipid management, heart failure management, and recently amyloidosis registry. We welcome her to talk about improving adherence to the guidelines of heart failure treatment.
شكرا. يلا. السلام عليكم ورحمة الله وبركاته. Good morning, everybody. Can you hear my voice? No? كده يعني yes or no? No. المايك شكله مش شغال. حطه فين؟ لا خلاص. Okay. Much better, I think. هذا طيب. First of all, I want to thank the organizer committee and of course the chairperson of the conference for inviting me for the second time and to talk about a very important topic. And I think maybe this is the first time that I appear talking about a selective topic in cardiology. and it's in Hail, maybe in front of pharmacists. I just want to ask, how many pharmacists do we have in the lecture room? If you're a pharmacist, can you raise your hand, please? So who did not? They are not responding, but they're not pharmacists. صح? Okay, no response. احنا لسه في بداية اليوم. طب another question. How many of you have a heart failure patient relative to him? One of his relative. Okay, and in Hail, lives in Hail. Okay, only 2? طيب, I'm asking this question not because actually I just want to take statistic, as دايما احنا الأكاديميين كانوا يتهمونا انتوا بس تبغوا معلومات تبغوا بس statistic. لا, هي الفكرة كانت because I want to see the journey of taking care of a heart failure patient. طبعا my topic is a very huge topic, and as usual, the large topics always in cardiology has to be said in a very short time, so you don't get bored from the topic itself. But I'll try my best to make the long story short, because I want to share with you the success story that we did in the cardiology field and in pharmacy cardiology. We all know that heart failure, it's a problem. أنا كنت في العصر اللي هو قبل 8-9 سنوات اللي كان يعتبر الهارت فيلير على أنها كارديولوجي. ما كان لها definition خاص فيها. And they used to say that I'm a cardiologist, I can take care of my patient. We had almost like 5-6 years of preparation, outreach, تبوك, الجوف, سكاكا, خميس مشيط, لفينا. نقول لهم no, heart failure, it's part of cardiology, but it's more complex. Why? Because of the numbers that you will see. A lot of death appears every year. Billions are spent to take care of those patients. And the end result, if you have a heart failure who need a transplant, it's the end. We don't have much of centers that take care of these patients. So, in Saudi Arabia, as I told you, we thought about, are we part of this? Can we solve this problem in Saudi Arabia? Do we have a problem in heart failure, or is it just a global problem that we don't have it here? So what we did, again, 10 years back, I think the very famous registry, and I was part of it. At that time, I was a student, and that's why now I'm leading the amyloidosis registry. I learned from this one how to do a registry. And why is it important? Because you need your own data. أمس فاكرين كانت في السيشن حقت الإيكونومي أنت محتاج your own data. Your country data. The source of information was our own patient. In the hearts registry, they found that we have 2 major elements of non-compliance because of, again, patients were not labeled. The other thing, they were not convinced that they should do a lifestyle modification and they should take their medication. So, from here, we found that we have a lack in pharmacists. I'm not going to say clinical pharmacist only, specialized pharmacist in this field. I remember I was the first heart failure pharmacist to be introduced in this field, and at that time it was not an easy job. I was just with a group of physicians. I learned the hard way, but it was very wonderful and very exciting journey that I would really like to share it with you. This is how our pharmacists think. So again, it's not an easy job. We need to prepare those people. We need to make them do a lot of work that you're going to see in the coming few slides, because in the end, you as a pharmacist, the network of the whole team. So in Saudi Arabia, they established clinical pharmacy in almost 80s. Lots of graduates came from King Saud University, and then follow suits the other universities. The first clinical pharmacist was rounding in the ICU setting. I remember he was graduated from US. And then we have our society now. Then we had even more and more. We have specialized groups in each society, oncology and cardiology and so on. So again, we're trying to fit. We're trying to do something for our patients. But again, what else? We're talking about strategies now. Strategy means that you have to put at least a 10-year plan. Number 2, I need to do a design. And how to do a design was something very new for us. We didn't do this before. And from there, we learned that it's the human resources, education, And look at this. I'll just try to show you that in more details in the coming slide. We don't have guidelines at that time, so we had to do a national guideline. That was the first time we have in Saudi Arabia through the Saudi Heart Association. And again, this is our elements. These are the team. So again and again, are they going to approve for you the full team? Are we really going to use them daily? Is it a cost effective? Now again, we come to the second part, where you have to be the one that decides which one should take over and which one should not. The physician will not be able to do this because they are very busy with their patients. So what we did, after we did the outreach, we introduced heart failure everywhere in Saudi Arabia. I was the only female at that time, and it was very hard because we used to go sometimes to places where there's actually no place that we can sit in. So we used to go in the morning, come back in the evening, definition of heart failure, types of heart failure, the role of each one of us, and so on. Then we went to King Saud University in the cardiac center, and we said, we're going to establish our multidisciplinary program, and it's going to be specialized for heart failure. Again, you can see there is the design, the content, of course, the elements, and this is not enough. Always, when you want to start a plan, you should have the strategy for 10 years, the elements, and very important for us is the pathway. Because let's say I have the program, but I don't know how to run it. It will never work. So we said we're going to have the patients tackled from everywhere. So patients either come from the ambulatory care or from inpatient. Inpatient could be in the ward, CCU, emergency, whatever. All this has to be covered properly. And that was the pathway. So we used to catch any heart failure patient who's labeled and diagnosed by a cardiologist. That is our patient that we have to have in the program. That's not all. We had a unit called the Heart Failure Clinic where it has everything in. ECG, echo, everything. I want to follow my patient in. They are there, and I can see them even more frequently. So I have a full schedule for my staff there, and I have a full staff occupied there, and medications, of course, for those patients. Look at this. We used to have it once every week. Then we had it twice a week. Now it's running 4 times a week. And the walk-in clinic now also has an indicator, the adherence of my patients to my walk-in clinic to see the outcome. And again, always, the most very important element for me is the physician, pharmacist, and nurse. All the extra, they are important, but you don't need them daily. So you have to also do something called cost effective that we said about yesterday. How are we going to run this? Through the strategies that we had it. We said, okay, all of us should know how to ask the question. I need to dig for the symptoms, not only physicians, all of us. GVP, all of us now know how to read it. ECG and echoes, when to ask for echo. Even as a pharmacist, I should ask for it because I need it to see the outcome of my patient, the lab work, the kidney, the thyroid, and so on. So something is a standard for all the staff, but there's a specified things for the physician to do, for the nurse to do, and of course for the pharmacist. Sometimes I can see the patients alone. I don't need the physician to be there because it's just a kind of optimization of the medication. But again, patients do never come with heart failure medication only. So you should have a good background about the other medications they are on, and of course to measure the adherence of this medication. We're a human being. I know we might miss something. We need to have our tools to help us in memorizing everything about the patient and documentation. With this documentation, we're able to do a database for our patient, and now we have almost 2,000 patients and at least not less than 5 years. Again, I can get from it whatever data I want because it has a very good documentation. That's not all. You need also your colleagues from other specialty. So you have to have a pathway for the interaction between the different specialties that are going to cover your patient. And sometimes you need them urgent. So you have to have a good, again, referral system and, of course, presentation. This is all part of the establishment. Now, I need to focus on the GDMT, and this is where the clinical pharmacist has a role in. And this is where we have been trained, at least for me, I have been 3 years training in Malaysia to make sure that I'm getting the proper dose for my patient. The proper dose for each patient is different because you need effective, tolerable dose for each patient. Sometimes you need to have the 4 medications together. Sometimes you need to have one by one. And sometimes you have to start it according to the guideline. So we have the 4 pillows there. Has been proven to be all of them 1A. So all the 4 medications has to be introduced. Whatever the way you're going to use, it's your patient, your plan, and your follow-up. So again, that is the Saudi guideline even, that really supports the global guideline. And with the editing that we did, we were able to update our guideline and introduce the SGLT2 inhibitor that was just introduced recently. So we have an updated guideline, we have a checklist, we have a clinic, we have a system, we have a staff. Let's start. I'm expecting in this time we're going to have a very good data that we can share with you. And I took the permission from our center to introduce for you our results, beautiful results that I'm so proud actually to talk about. But again, make sure that you have a patient with the GMT, GDMT, 4 pillows. The starting depends on the school that you come from, but you have to follow the guidelines that will tell you within 4 weeks you have to introduce 4 of them, not like the old school. Another thing very important, part of the medications will work on the mortality, other part will work on the morbidity, and some of them just for relief of symptoms. All this has to be there. You have to be equipped, well-knowledged, and then you can start. So you can see it's not an easy job. It's a very huge, actually, responsibility that I took, and I couldn't now shy away. I'm stuck there. And I'm happy that I'm there because, again, you can see the effect of your recommendations directly on the patient. We did different phases, different trials, and so on, but now we are coming to the last part. But again, I want to tell you something. We have data for those patients before we started the program, and it was our database. And then from there, we applied the program, and we saw the data before and after. Just a brief information about the database. You can see now we have almost 2015 up to 2022. It's almost 10 years. I did not involve the new ones, not yet because I'm just waiting for some more results to come. But you can see we have male more than females, Saudi are more than non-Saudi, and so on. So these characteristics is important for me. I can get from there at least the comorbidities that related to Saudi Arabia. And again, that's not all. I can tell also from the genetic part of those patients what kind of complications I'm thinking of. And you will see that by, of course, more data. Now again, what I'm focusing on now, because I cannot, of course, introduce the whole data, the GDMT. Since I started with them, I was trying my best with my team to put the patient on the proper GDMT. From the checklist, you saw that we have 4 elements. Even the ones you tried on them and they did not respond, or you cannot give them, but you justify they are adherence, they are compliant. So this is very important in the measurements because there's a difference between missing it or giving it, but you cannot. So this is called adherence, a positive. And from there, you can see our statistic now. Most of the 4 pillows are there, and our statistics are very beautifully raising and telling us that we're doing a good job. What about the 30-day readmission? And this is one of the indicators, global indicators, that tells you, did you discharge your patient immaturely? And then you can see now we are improving. It was almost 10, now we're 5.7, although there's a little bit of fluctuation during the years because of COVID sometimes, because of difficulties in opening the files and so on. So it will give you a direct answer if there's any obstacles happening in your practice. So again, that's another KPI that we really worked very hard to improve it, and it has been proven that is improved. Now the adherence point, and this is actually to the appointments, because again, we have a rule there. The patient who do not come or do not show 3 times consecutively with no reason, they are discharged. So that's why you have to be sharp sometimes to teach your patient that you are precious enough, not just for us, even for yourself, to take care of your health. So this is, you could see now the adherence after telling them how important they are, how important is the plan. It has almost been actually very important in the newly even diagnosed patients. That's not all, even in the follow-up. Before they used to have 2, maybe appointments in a year. Now we have some of them having like 3 or 4, but still the adherence is improving. Why? Because they have to come and see and talk to us. So now they trust us. They come and tell us, what should I do? Now, the full picture about the compliance, you can see it now how beautiful it is. Compliance here now, the last one is for everything, for the drugs, for the appointments, lab work, and so on. So all these elements has been studied and proven that it is really going to the right side. Again, optimization of medication, and it was itself a nightmare for me and for my team, because sometimes you increase a drug and then side effects appear, then you have to shy away. And then you have to introduce it again and so on. So to go to that level, optimization, that means you are doing a good job. Your patient is becoming better, their heart is becoming stronger, and they are able to go up with their doses in the effective side more than before. And I think this is by itself, it's a very good achievement. Again, adherence, we did a lot of things to do with our patients, alarms, system, whatever, WhatsApp, just to tell them about their medication, and their adherence has really been improving, and I think we still have things to do more in the coming future. What about the specifically medication adherence? We used on them the Moresky score, and I know all our clinical pharmacists know about it, and most of them have a very good score now, and even more than 80%, and this is a very good news. What about the quality of life of heart failure patient? And this is why we are here, because actually all this is for the quality of life. I don't want a patient who lives 10 years, but he cannot move around, with a patient that could live just 1 year, but he's totally dependent on himself. Because what we look at, our beloved, we want them to live forever, but you want them to live happily around you. So again, quality of life was a very important element for us. We used the Kansas questionnaire. I think all of us know about it, and this is a way where you measure their quality of life. We translate it to Arabic. يعني كان يقول مثلا اقدر اروح البقال ولا لا، احنا كنا نقول تقدر تروح المسجد ولا لا، كم مره تروح المسجد، الاهل، الزيارات، العزايم، هذه كلها related to our culture, and we had their approval, and it's the Arabic version, and we used it every year to see the quality of life beautifully. Alhamdulillah, we have very good scores now, and it's for 5 years. Again, that was actually our message, that communication was important, not just to each other, even to the patient, to the caregiver. So if you don't show the patient how, first of all, valuable they are for you, if you don't do a networking, if you don't care of the prescription and the drugs that you are giving to the patient, if you don't look at the explanation, proper explanation, what you are doing and why you're doing this, and then in the end, if your patient is not part of the treatment plan, you will never, ever succeed. And again, being part of the team is a very actually important message للزملاء والزميلات إن شاء الله القادمين في المهنة. ما في حاجة اسمها أنا work alone. My message here is that we are working, completing each other. We're not competing with each other. So either زملاء الصيادلة في الأقسام الثانية أو مع حتى الأطباء والتمريض، إحنا بنكمل بعض. وفي الآخر الفوكس هو المريض، ومريضك هو الأساس في كل شيء أنت بتسويه. So, thank you very much.
Thank you, Dr. Fakhr, for covering this complex issue in this limited time. Appreciate your effort to summarize your experience in King Saud University Cardiac Service. Our next speaker is my dear colleague, Dr. Naif Al-Ghassab. He is Assistant Professor at حائل University. He is our Service Line Director of the Cardiovascular Service in حائل Health Cluster, and he is an interventional cardiologist. He will talk about the accumulative effect of LDL exposure, mainly concentrating on inclisiran.
ايه شغله بس. السلام عليكم ورحمة الله وبركاته. First, I'm very grateful for my colleagues and for حائل cluster represented by our colleague Dr. Ali Twinawi for organizing this summit. We're going to talk about hopefully the cumulative risk of LDL and role of inclisiran. So this is my disclosure. We're going to start with a case that probably going to delineate how we're going to implement the non-statin products in those circumstances. So this is a 50-year-old lady who presented as a working nurse shift with elevated blood pressure and heavy smoker. She had a previous family history of premature coronary artery disease using combined oral contraceptive. Blood pressure 3 times measured, and it showed that there is an average of above 150 millimeter mercury. She's having a BMI of 31. Those are the lab tests, as you can see, that her hemoglobin was around 13.3, hemoglobin A1C was around 6.6, and creatinine was around 0.72. And LDL measured fasting around 12 hours, around 182. So we did an eGFR for her, which came up to be around 91. And what we used for that, the calculator that was provided by ESC. In those circumstances, ECG is mandatory for all patients presenting to our clinic. That did show that there is an LVH, which is probably an effect of high blood pressure in those circumstances, meaning that probably is a chronic disease ending up with end-organ damage. So let's see what the ESC latest guidelines would say. So she's a 50-year-old and she's a smoker, family history of coronary artery disease, hemoglobin A1C of 6.6, and eGFR of 91, probably affected by diabetes, and LDL of 180. And in those circumstances, do you think she's a low risk or moderate risk or a high risk or very high risk? In the latest guidelines, she probably lay down to be a very high risk in those circumstances, and I'll tell you why. So you know that the SCORE and SCORE OP risk prediction algorithms recently, those are prediction algorithms that were made in European countries involving the Northern African countries. And it has a 6 prediction predilection in those circumstances made over almost 500,000 through the population and targeted certain countries. And if you can see, if we delineate our patient here, that she's a very high risk in around 13.7% to have coronary artery disease. For a SCORE OP, those are the patients above the age of 75. What the ESC guidelines would say. So if the patient presenting to the clinic, the first thing we do, we should really ask him to stop smoking, lifestyle modification, and ask him to have a systolic blood pressure probably less than 160. So starting probably with antihypertensive medication. And her age is around 50 to 69. So her estimated risk of 10 years is around more than 10% in those circumstances. So you can use the heart score that can help you a lot with this. And you can see the high-risk countries demonstrated in this map, those Northern African countries probably, and we can really extrapolate. Our countries are really not included in the study. We have to have a study that includes our own, but if you have more than 300 cardiovascular deaths for each 100,000 population, you are at a higher risk. So what are the risk factors that we usually plot? Is that the age, the sex, and systolic blood pressure, non-HDL, and smoking status. So for our patient, we go with the age about 50 to 69, and if you estimate the 10-year risk score, she's at 10% or more, especially with the previous family history. So we wanted the LDL to be less than 100 in those circumstances. And then we can look to every patient and do a risk enhancer, meaning that if we achieve our target and our goal, if we want to go further with this patient, we can do a risk enhancer, and then we can achieve targets of less than 70 or 55, depending on which guidelines we usually follow. So the cardiovascular risk that we have in the recent guidelines, we talk about cholesterol that she has is around 255, EGFR, that means diabetes with end organ damage. If you do urine analysis for this lady, there will be proteinuria there. And systolic blood pressure, and there is a left ventricular hypertrophy. That means the muscle or the myocardium got affected by high blood pressure. And as you can see, so diabetes with target end organ damage or severe CKD, obviously, calculated score of more than 10, or family history with atherosclerosis or coronary artery disease, it's plotted there. So target organ damage usually presented with microalbuminuria, retinopathy, or neuropathy in those circumstances, and it's written well here is that the proteinuria, renal impairment, or EGFR more than 30, or will be left ventricular hypertrophy or retinopathy, just to look for our patients. So what happened to this lady is that she got started on combined pills, which is the amlodipine and valsartan, and then she achieved the target and started on metformin and dapagliflozin, and then obviously, we will not start the combined pill of atorvastatin and ezetimibe. In those circumstances, we will try to our best lower her LDL. If we can achieve that target, lowering LDL, as you can see the schedule of a 60% lowering, that if she is a 180, she will go down up to 72. But delineating the goals usually depending on whether high intensity given for the patient or not. We usually start gradual. If we achieve our target, well and good. If not, then during that time, probably we'll ask for non-statin agent. What the American Society of Endocrinologists say that for every patient presenting, usually with a progressive atherosclerosis or established atherosclerosis or history of premature coronary artery disease, and those population, usually we can go with a target of less than 55 in those circumstances if we achieve those levels for further reduction. Patient came a few months later saying, well, I have a lower limb pain, and you check that the CK is really on the higher side. So in those circumstances, what are you going to do? The non-statin agent. Here we come with a JACC recently published article that we can start the non-statin agent, including the eviculumab, allocriumab, or inclisiran. And you can see it and see it there. The second written is that in those patients with ACS did now achieve target of less than 70, in that time probably a non-statin agent is indicated in the circumstances a class 1 indication. So RNA agent, I will not really bother you, just I will remind you those are molecular agents that can target they are monoclonal antibodies, especially BCSK9, well-known Repatha, and other medications. But yearly, you will be totaling to have 2 to 5 grams of this medication, and the frequency sometimes can bother the patient. So always, we have a clinical evidence to follow. And the same thing is that we wanted something that with a longer frequency, so it will be more convenient to the patient and more convenient to the hospital, because a frequent visit will require frequent investigations, and those circumstances, more burden, financial burden. So will not really bother you with the available agent, but just a reminder, a quick reminder that those agents that we have, there are statins probably can act on number 2, as you can see. Number 5, where the inclisiran usually act as a small interfering RNA messenger on small interfering messenger RNA, and BCSK probably will act on the actual protein after production. So it is more convenient if we target the cell inside the liver than targeting the byproduct of the cell. So this is really resounding well and good, but is it efficient or not? So those are the studies, the Orion studies. So we have starting from number 1 to number 11. So basically, the first one is a phase 2 trial that was conducted, and the study year was around 2017. They took a sample of 500 patients, and in this first trial, they tried different medication doses. So they wanted to see where are the clinically efficient dose with the least amount of medication or monoclonal, all the antibodies that we're going to give that can really be convenient to do LDL and BCSK9 reduction. And during that time, they achieved a good reduction of LDL. We're going to talk about it later. Another phase 2 trial, which is the same, the Orion 3, and it's a phase 2 trial including a 490 patients. And it did really showed also a reduction, but we're going to talk about it because what kind of population included in those studies is very important. if you include someone with atherosclerosis, either primary or secondary prevention, or you included those homozygous or heterozygous that my colleague going to talk about. So the efficacy of the medication depends on the actual etiology of the molecular mechanism why the LDL gone up in those situations. We have the Orion 9, 10, and 11, and all of which Orion 9 included homozygous, familial hypercholesterolemia, and atherosclerosis in Orion 10 and Orion 11. And we can see that those are phase 3 trials. And the one conclusive probably would be Orion 8 that include all the studies from 9 to 11 or to 12. So the number does not really mean the actual date. So some of the studies really finished earlier than the others. That's the reason probably we wanted to include those studies. So expected for Orion 4 that 15,000 patients probably taking the medication to finish on, during the year 2026. And as we can see, this is the first trial that we talked about. They gave the medication during day 1 and day 90, and then they tried different dosage. And they found the least dosage probably that would convey the clinical significance is that a percentage change that we get is that, as you can see, is around 60% PCSK drop and around 40 or 40-ish% in LDL reduction. So they use the 2-dose protocol probably, a single-dose protocol to convey into an actual clinically significant results. From the first dose, yes, it was there, but to sustain the actual drop in LDL and PCSK9. So the actual second study that was conducted here for familial homozygous. The concept here is that whenever we try to give this medication, trying to trigger, to decrease the number of receptors, certainly at the beginning it's more appealing to include all the genetic mutation. But when they included the homozygous, some of them, they have absence of the receptor. So whenever you give the medication, it will not give a clinically resounding significant results because the receptor is absent. So the actual biomolecular mechanism for this medication is not really clinically resulting into significant results. So choosing the patient or an appropriate patient group is very important in those circumstances. For Orion 3, as you can see, it's an open label probably taken from Orion 1, and they followed those patients over 4 years and giving the medication they started one for every 6 months, and then following the clinical results. So they sustained the level of LDL reduction for almost 40 to 50%, plus PCSK9 reduction. And as you can see here, some of the patients with evolocumab probably converted to the other medication, and still there was a sustained reduction in all the followed patients there. So as you can see, different familial probably included, you will get different results. So is it really convenient? So this is inconsistent. So that's why we need more to dig deep into the actual mechanism of how the LDL results gone up. So as you can see here for Orion 9 probably, this is for heterozygous familial hypercholesterolemia. And this is probably of partial absence or partial gene mutation of the receptor. Still, it is effective, and it did really resulted into significant reduction of actual LDL cholesterol level and PCSK9. And this is a great reduction achieved into different multiple variants, whether two variants included into the actual gene testing, or a total LDLR variants, or LDLR pathogenic variant, including all the group. So for the other two studies, for Orion 10 and 11, as you can see, it's a phase 3 clinical trial, and they included patient randomization 1-to-1, and in those circumstances, inclisiran of 300 milligram given. And as you can see, so this is the percentage of LDL reduction, and it did convey into significant LDL reduction and PCSK9 reduction. And as you can see, both plotted, over both sides. And as you can see, inclisiran performed way better than the actual placebo group with the LDL reduction, especially with usual treatment that we had. So as I told you that the Orion 8 included probably 1, 3, 9, 10, and 11. And all of these patients looped up together and followed for 3 years. As you can see, the end of study results around 1,000 days. And after that, they caught up around 2,446 patients. And this is one of the last studies that was published 2024. As you can see, most of the patients
Europe Society of Cardiology, in collaboration with Europe Atherosclerosis Society, they have released a clinical guidance or consensus statement in 2023 regarding management of homozygous familial hypercholesteremia. The potential benefits of early diagnosis of FH and therapeutic intervention. As you see in this figure, if we start early with medication, let's say even with low dose of statin, we will get more survival and benefit. So that's why the beginning of treatment at let's say 5 years of age, if diagnosis confirmed, is better than delaying the treatment after, let's say, 10 or 12 years. This is algorithm shows that the management or approach to homozygous familial hypercholesteremia, we have to start with homozygous familial hypercholesteremia patient in combination with high intensity statin and ezetimibe. Within 8 weeks, we have to add PCSK9. Usually in our practice, we are starting with triple therapy directly. Since we are talking about an LDL with homozygous familial hypercholesteremia patient more than 10 millimole. So statin and ezetimibe alone, they are not expected to reach the LDL target. So the important thing is here. When you start the triple therapy, you have to look if the patient achieved LDL reduction more than 15%, so we will consider a response of PCSK9 inhibitor. If no LDL reduction more than 15, this means we have to go directly to the advanced therapies such as evinacumab or lumitavide, in addition to lipoprotein aphrases. The goal as well in those population, we are considering 55 milligram per deciliter, which is less than or equal 1.4 millimole. And the importance of these advanced therapy is to reduce even the lipoprotein aphrases sessions. If in patient without using these advanced therapies, they need to lipoprotein aphrases every 1 week, every 2 weeks. So I have seen patients with those advanced therapies, they need only for 1 lipoprotein aphrases per month after initiating evinacumab or lumitavide. So the current treatment for the management of homozygous familial hypercholesteremia in this systemic review, long-term data reported from recent studies showed that all intervention lower LDL levels with evinacumab have the most rapid and sustained effect. We have 2 molecules now for homozygous familial hypercholesteremia. We are talking about lumitavide and evinacumab. Lumitavide started dose 5 milligram and need for up titration and need to consult as well the clinical dietitian to restrict the patient on low fat diet. And evinacumab is a once per month injection, IV injection 15 milligram per kg. The most important thing is the safety profile. From my experience, I think if you start your patient with medication such as lumitavide with strict diet and continuous follow-up and education and monitoring, you will get the expected result and everything will be okay. If started patient on evolocumab, mainly you don't need to monitor your patient for let's say side effect that's common with leukotopies such as fatty liver. I have recommendations. I would like all of our colleagues, they consider these recommendations. We need to increase the level of awareness. We need to focus on advocacy, screening and testing and diagnosis our patient in early stage. And we have a story. I always mention this story. Our community needs to be screened even in a community campaign. In حائل, we have an experience. We have did a presentation in Arabic language, and we goes there, and we talk to them regarding the signs and symptoms of familial hypercholesterolemia, how you can screen yourself in early stage, and even we have starting opening their file at the community campaign. And if patient suspected to have familial hypercholesterolemia, we have booked an appointment in 2 weeks. So we catch, as I remember, 2 to 3 patients from this period only, homozygous familial hypercholesterolemia. So the community, I believe, the community and campaign, you will find many patients underdiagnosed, and you can offer the medication for them. Registers as well, research, we need to focus on them, and cost and value of this medication is well documented, and the value is better. As well, we have did booklet in Arabic language, and we have released this and published this booklet to the community through the حائل Health Cluster official account on Twitter as well. I have great news. Last month, a study analysis of Danish registry data from 1978 to 2021 found that the mean age at which individuals with familial hypercholesterolemia were diagnosed with coronary artery disease increased from 49 in 1978 to 61 in 2021. While the mean age at death increased from 50 to 78. In 2021, the mean age at coronary artery disease diagnosis was 7 years younger in individuals with familial hypercholesterolemia compared with those who did not have familial hypercholesterolemia, while the mean age at death was comparable in those with and without familial hypercholesterolemia. The improved prognosis of familial hypercholesterolemia likely reflect the advancement in the treatment of familial hypercholesterolemia. As well, for whom who interested, the European Society of Cardiology will update their dyslipidemia guideline by end of August 2025. And the American College of Cardiology and the American Heart Association will update as well the blood cholesterol guidelines by beginning of January 2026, inshallah. Thank you all.
if there is no question, I can start myself to ask our colleagues regarding the primary prevention. We know the cost. Yesterday we have a great talk about value-based medicine or cost effectiveness. How early we should start, or we can start primary prevention for
Great question, Doctor. Yes, nowadays the dyslipidemia is a major topic, and a lot of studies showing the reduction of LDL is associated with the reduction of MACE, and the guidelines also recommend for the primary prevention and screening, as Dr. Ali said, for the familial hypercholesterolemia and patients with the risk of coronary artery disease, premature history of premature coronary artery disease, multiple risk factors, age more than 40s, all of those patients need to be screened for dyslipidemia. So it is really challenges, and a role of family medicine and primary care is important to screen all of those. And even the patients themselves, they need to seek for screening for lipid, as now we have a good data about reduction of LDL, and earlier reduction will end with earlier more benefit for reduction of coronary artery disease. Dr. Naif, if you have any data.
Any adult probably deserve to be screened at least at a younger age. So if we are really talking about younger age, would just add to my colleague is that anyone above the age of probably 18, so at least to be screened, and if it's really familial hypercholesteremia, then probably earlier age to be screened, probably delineating probably at the age of 10, 11. It depends on the features, the family, probably history, that probably going to be looked up to be screened at earlier age.
دكتور الشناوي تفضل.
Just one point. I think, Doctor, I believe we need to test even our children after birth. Yes, they need to be screened at this point, especially in families that are at risk of familial hypercholesteremia.
يعطيكم العافية جميعا على السيشن الرائعة. أنا I have a question. يمكن كلمة السكرينينج تكررت يمكن في كل البرزنتيشنز. How can we expand the screening in practical way? هل فقط اعتماد على المراكز الرعاية الأولية، الاعتماد على المستشفيات، ولا can we involve the pharmacists في عمليات السكرينينج، و can we involve the community pharmacists في عمليات السكرينينج؟ كيف نحول موضوع السكرينينج؟ يمكن دكتور علي الآن كنت تقول إنه we have to increase the screening process. كيف to increase the screening process؟ شكرا جزيلا، يعطيكم العافية.
Excellent questions, Doctor. I think we have to have the initiatives, because now we have a good data about reducing LDL and the impact of reducing LDL, and multiple patients may be underdiagnosed, undertreated, as per Dr. Ali when he said, for the familial hypercholesterolemia, homozygous and heterozygous, and it is really, unfortunately, it's highly prevalent in our country. The study is talking about 50 up to 60% in our population, they have dyslipidemia. And most of them found by chance when they go to the primary care or did some labs. Awareness is important. The patient themselves, they should come to screen themselves. So we have to make the awareness, and also the primary care, they should do the screening for all patients who met the screening criteria. More than 40 patients with multiple risk factor, family history of coronary artery disease, prematures, they have to do screening earlier, as Dr. Naif said. So it is multi tasks, not only us as a healthcare professional, even the pharmacist, they have a potential to make this screening because the patient coming to the pharmacy all the time, getting medications. Dr. Ali make a good initiative in Raleigh Hail. They bought screening and they found 3 patients with homozygous, which is a rare condition, but 3 from this event, this means it is really prevalent in our population. And we are lacking unfortunately, we are lacking the registries in Saudi Arabia. So it is multitask and it should be done by high level. This is my opinion in this area. Dr. Naif.
Just to add one more thing is that classical teaching saying that dyslipidemia can start as early as childhood. Because lipid deposition really starts earlier after birth, as Dr. Ali said, and then lipid accumulation happens with the different frequencies. If your intake more than output, if you eat more than you exercise, ultimately this lipid gonna really start the lipid plaque process at an earlier stage. We are working in High cluster, and I came across a call for 11-year-old, who is having cabbage at an earlier age of his life, and recent liver transplant because of familial homozygous hypercholesteremia. So cabbage, which is bypass surgery, open heart surgery, can happen at a younger age. So we're dealing with a serious disease, not an actual benign one.
Thank you. I would like to add one just small comment that despite all our efforts to detect the patient who really needs to be on primary prevention as to take statin, we need also to keep into consideration that we should really give the statin for the patient who really needs this medication. I know that we have seen in the practice a lot of patient who has, for example, heart failure and he is on a statin. And when we ask the reason, they are going to say that he has heart failure, so he is at high risk for. That's not true. We should really select the patient. There are certain criteria published by the guideline. We should follow it to prevent the overutilization. We don't want to give the statin to all the community. We need to select the patient who really fits the criteria and expected to get the benefit of being on statin therapy.
السلام عليكم. خالدة العنزي، نائب رئيس التنفيذي للتخطيط والتحول في تجمع تبوك الصحي. طبعا I would add something. الوزارة في رمضان لو انكم سمعتم قادت initiative اسمها صم بصحة. كان الهدف منها انها تعمل 8 تيست، كلها سكرينينج ل8 تيست، كان منها الليبيد بروفايل، وصرفت وفعلا ضخت فوق 8 مليار ريال سعودي علشان التحاليل هذه. اوكي، كانت النتائج جدا، كان من ضمنها مو بس الديسليبيديميا، كان الديابيتس، البلاد بريشر، كمان بالنسبه لنفس الصحه القابضه. يعني عندنا من ضمن المؤشرات الرئيسيه اللي تشجع السكرينينج، اول شيء السكرينينج حطيتها كمؤشر بالنسبه للديسليبيديميا من المين كي بي ايز اللي موجوده على كل تجمع. السكند كي بي ايز اللي حطته على كل تجمع البيرسنت اوف ذا بيشنت كنترولينج مع الديسليبيديميا ميديكيشن. فهذه انا اتوقع انها من الاشياء او الانيشياتيفز اللي راح تسرع من عمليه السكرينينج ويصير في عندنا فعلا سكرينينج افضل. اوكي، لانها مو بس البرايمري كير غطت السكرينينج. اوكي، الحين ما في اي برايمري كير الا من ضمن مستهدفاته انه لازم يعمل سكرينينج، لازم يغطي. اوكي، عنده تارجت معين نهايه السنه لازم انه يوصل لها. فاتوقع انه على ليفل الناشونال الصحه القابضه او التجمعات الصحيه قادت هذا الموضوع بنجاح كسكرينينج للديسليبيديميا، للهايبرتنشن، للبلاد جلوكوز ليفل او الديابيتس. ف السكند ستيب هنا راح يجي احنا دورنا كفارماسيست. اتوقع السكرينينج انتهينا منه، دور اللابوراتوري ودور الفيزيشن. الحين دورنا احنا كفارماسيست هاو تو كنترول اند شغل الكلينيكال فارماسيست هذا الحين حاليا.
يعطيك العافيه دكتوره خالد.
احب اوضح شيء يا جماعه. انا يمكن ماي كويستشن يمكن ينفهم بطريقه خاطئه. انا ماي كويستشن، انا ما ابغى البيشنت انه هو ياخذ موعد ويجيني البي اتش سي او يجيني المستشفى واسوي له السكرينينج على اساس ان انا اعرفه سواء في الهايبرتنشن او في ديسليبيديميا او في اف اتش في اي ديزيز. انا هاو كان اي ابروتش بيشنتس خصوصا لما اكون عارف انه في هاي بريفالنس كبيره ممكن الهايبرتنشن. ولذلك انا اي منشنت حتى كمان الكوميونتي فارماسي، لان الكوميونتي فارماسي البيشنت بيزورها او الكوميونتي بيزورها without any appointment. فهنا ماي كويستشن، انا ما ابغى بيشنت ياخذ معايا موعد لانه هو اذا اخذ موعد عرف انه عنده مشكله. انا ماي تارجت في السكرينينج خصوصا الناس اللي ما عارف انه عنده مشكله. how can I increase السكرينينج للبيشنت اللي ما يعرف، اليونجر ايجز، البيشنت اللي ماشي في الشارع اعتيادي ممكن يكون عنده hypertension بس without knowing that he's a hypertensive patient. how can I increase this؟ هل فقط هذه مناطة التجمع الصحي؟ هل هذه مناطة بالمستشفيات بالبرايمري هيلث كير سنتر؟ ولا انا ليش قاعد اقول للكوميونتي خصوصا؟ لان الكوميونتي بيدخلوها everybody، يتسوق يجيب اي شيء في الايام هذه. فهاو كان وي انكريز ذس if there is a possibility؟ معليش انا اعتذر للاطاله يعني على هذا السؤال.
انا عندي ممكن بس سؤال دكتور شناوي، خطر في بالك انت تسوي سكرينينج لنفسك؟
يس،
ايش كان السبب؟
طلعت اشياء كثيره جدا وبعد كده بطلت، قلت لا انا ما راح اسوي لنفسي بعدين.
بس لا سؤالي ايش كان السبب؟ ليش سويت سكرينينج لنفسك؟ ولا كان في عارض لا سمح الله؟
بس اي شيء يعني للتشيك اب. يس ريجولار تشيك اب.
I think what should happen يعني هي الحوكمه في الامور هذه، تشريع الامور. زي مثلا فحص الزواج اللي كان فرضوه، فانت ممكن مثلا ما يدخل الطالب الجامعه الا هو عامل مثلا فحص دهون مثلا. طلاب المدارس ما يدخل مثلا الا هو مع التطعيمات وفحص الدهون في حاله فاميليال الهايبرليبيديميا. فانا قصدي هي تتحط من الدوله بحيث انها تشرع بطريقه فيها بريفنشن. فكده انت في البدايه حتفرضها، بعد كده حتصير خلاص هابت. فاي ثينك هذا حتكون يمكن الاجابه الامثل، والصيدلي بارت اوف ات، لانه انت في الاخر يعني حيسويها اي احد، كوميونتي فارماسي، هوسبيتالز. زي فحص الزواج بالضبط، لما بدا في البدايات كان اوبشنال، بعد كده صار يدخل فيها بعض الاليمنتس. الحين ما في عقد قران الا في هذه الفحوصات، فاعتقد هذه يمكن اسلم طريق. ولا ايش رايك؟
And Dr. Fakhr, thank you for your comments. This would bring up another question. Is this going to be cost effective to screen all the population that would go to the university? How many patients, how many of them would be candidate? So this is another question that will be raised up.
يعطيك العافية دكتور فيصل. هذه نقطة مهمة جدا، وأعتقد أنه مبدئيا I cannot say انه cost effective، بس ال cardiovascular disease or cardiovascular death هي still حتى الآن هي التوب cardiovascular أو cause to death حتى. فأنا إذا يسمحون لي ودي أقسمها إلى قسمين. ممكن تبدأ في two initiatives. الانيشيتيف الاولى زي ما بدات الانيشيتيف حقت مثلا صم بصحه، يكون في انيشيتيف على الليفل ناشونال ليفل دكتور، ومنها المبادره هذه ممكن الكيتس حقت مثلا الليبيد بروفايل تكون موجوده بالكوميونتي فارماسي، ايذر بسبورت زي الريجستري من الفارما كمباني. الحين يزعلون عليه يقولون بس تسحبون منه، بس بالأول والأخير هذه فيها فائدة كبيرة للمجتمع. والجانب الآخر اللي هو الإديوكيشن وهو الأهم. صدقوني والله يا دكتور والجميع، أنا شفت مرضى أعمارهم 18 ما كانوا عارفين ان في دواء اسمه لوموتابايد، في دواء اسمه ايفينكيوماب، فيه ما كانوا عارفين الا انه حلك يا غسيل او فقط. ففي عدم وعي عند المرضى انه في ادويه في ريجستري بالوزاره، الدواء افوردبل. فالمجتمع يحتاج توعيه، واعتقد انه افضل مكان للتوعيه انه نروح حنا للاماكن تواجد المجتمع حتى.
So it was a simple question. Now we get a lot of complicated answers. I think that, as mentioned by Dr. Fakhrat, by Dr. Ali, it need initiatives from the Ministry of Health, from the other sectors like universities or insurance companies to be obligatory to do all these tests for young population. I have another burning question, if you allow me, for Dr. Naif and Dr. Faisal regarding de-escalation of the dual antiplatelet. What we see from our practice, many patients remain for dual antiplatelet for many years after BCI. I don't know how we can change this current situation.
Great question, Dr. Halim. So de-escalation therapy, there are a couple of few studies talked about de-escalation therapy, but it's not as simple as this. So you can de-escalate the therapy basically based on a couple of few things. First, the type of stent that we usually put sometimes for those patients. If we put the stent in the left main, I would not think of de-escalation earlier. A complexity of the lesion of the coronary artery disease. So in those circumstances, probably I will not really de-escalate earlier. And those also circumstances where the stent is too long and there are other allied factors, probably risk factors with the patient. So de-escalation, we usually don't take it as simple as this. We usually think about risk factors plus the patient profile and the type of stent, where it's put, and the anatomy of the coronaries, and in that time probably we'll decide upon de-escalation or not.
Thank you, Dr. Halim, for your nice question. The de-escalation, the meaning of the de-escalation is that when we shift from the ticagrelor or prasugrel to clopidogrel. This is what, does this what you mean, Dr. Halim?
This one issue, and moving from dual antiplatelet to single antiplatelet. Let me give you a scenario. Many patients did BCI 3-4 years ago and they still on dual antiplatelet.
Well, then the standard duration is 1 year of dual antiplatelet. Extending the period beyond 1 year, it depends. It's going to depend on the case itself. For example, if you have patient who has multiple MIs, recurrent or strokes plus MI, multiple events, then you could extend the duration. However, there are common scores that we could use and it has been formulated to guide us regarding the duration of the dual antiplatelet. We have the DAPT score and we have the precise score. These scores would help us to decide whether to continue beyond 1 year or to discontinue the dual antiplatelet and to continue with aspirin alone.
So any other question from the audience? So I think we reached the end of this very exciting session. Thank you for all speakers and thank you for audience.
نشكر المتحدثين على هذه المحاضرة المثرية، وأدعو الدكتور علي تبيناوي أن يبقى متكرما على المسرح لتكريم المتحدثين. الدكتور حليم شمسان. الدكتور تركي عسيري. الدكتور فيصل القرني. الدكتورة فخر الأيوبي. الدكتور نايف الغصاب. حضورنا الكريم، أترككم الآن لاستراحة للقهوة والتعارف لمدة 10 دقائق لنعود لاستكمال برنامجنا العلمي. ضيوفنا الكرام، أما الآن ننتقل إلى الجلسة الثانية لهذا اليوم بعنوان Advancements in Diabetes and the Endocrine System. جلسة سنتناول أحدث التطورات العلاجية في إدارة مرض السكري وأمراض الغدد الصماء، مع مناقشة الحلول المبتكرة التي تهدف إلى تحسين جودة حياة المرضى. تدير هذا الحوار أستاذة مشاركة في جامعة الملك سعود، كما أنها خبيرة في مجال علاج أمراض السكري ومجال الغدد الصماء. رحبوا معي بالدكتورة جوزة السبهان.
السلام عليكم، حياكم الله جميعا وصبحكم الله بالخير. في البداية أحب أبدأ كلمتي كلمة قائدنا وملهمنا سمو سيدي ولي العهد الأمير محمد بن سلمان حفظه الله، حين قال نرحب بالحالمين. مجرد عبارة إنما هي خارطة طريق لنا جميعا. أنا متأكدة أنه مؤتمر حائل للعلاجيات كان حلم، وأصبح مؤتمر حائل للعلاجيات الثاني، وإن شاء الله بيكمل وبيكون الثاني والثالث والرابع. والأجمل أنه هذا المؤتمر في مدينة رائعة، هي مدينة حائل. الحمد لله، حائل الأجمل كما يسميها أهلها، بجهود أمير منطقة حائل الأمير سعد بن عبد العزيز، الأمير عبد العزيز بن سعد حفظه الله. وطبعا الشكر لكل حالم أنه يحقق حلمه وتظهر على أرض هذا الوطن الغالي، والشكر موصول لتجمع حائل على عقد مثل هذا المؤتمر العلمي المتخصص في الأبحاث وكذلك في الأمراض المزمنة في منطقتنا. الشكر لمنظمين المؤتمر العلمي على رأسهم الدكتور علي بن فارس البيناوي على الدعوة وعلى اختياره هاللجنة المنظمة والإعلام. اجتهدوا وسهروا وتعبوا وبرز هذا المؤتمر، وشكرا لهم، لأنه حائل مو بس الأجمل، حائل الأعلى علميا. وأتمنى أنه توصيات هذا المؤتمر تتخطى هالقاعة وتكون زي ما ذكرنا من التوصيات اللي تحسن جودة الحياة للمواطنين والمقيمين في هذا الوطن الغالي. Let's start our session with Dr. مرزوق الغفيلي. The first presentation will be with Dr. مرزوق الغفيلي. He's a completed Saudi fellowship in diabetes management at King Faisal Specialist Hospital and King Fahad Medical City. He will present updates in management of type 1 diabetes. The floor is yours, Dr. مرزوق.
Okay, first I would like to thank the organizing committee for organizing such a great conference, and I would like to thank him again for giving me this opportunity to present what's the update in diabetes type 1 management. First, there is nothing to disclose here, and the objectives that when we talk about type 1 diabetes, the diabetes technology is the first things that we should mention. Then we will touch briefly about the type of insulin, and we will end up with the Lantidra. Hello? Anyway, when we talk about diabetes type 1, we need to know a little bit or a small abbreviation or a definition of type 1 diabetes. And it's the diabetes it's involving the immune-mediated destruction of insulin-producing pancreatic beta cell, leading to insulin deficiency. From that simple definition, we understand that the ultimate treatment for type 1 diabetes is insulin, and the all updates regarding that, it's whether how you give insulin, the way giving insulin, and what type of insulin. So to understand the type 1 diabetes in precise, we have to understand how common diabetes it is type 1 in Saudi Arabia. And we can see that we are in the top 10th countries in the prevalence. We're ranking number 10th, and also in the incidence ranking number 9th. So that's give us a hint that type 1 diabetes need to be facilitated in form of their needs, technology, and upcoming researches. Diabetes technology, what we mean by that, it's a term to describe the hardware, devices, software that people with diabetes use to assist their self-management, ranging from lifestyle modification to glucose monitoring and therapy adjustment. It mainly divided into two categories. The first one, the insulin administration, whether by pen or insulin pen, etc., or glucose assessment to know what's the blood glucose reading. So like blood glucose monitoring and continuous glucose monitoring, and it's called CGM that we will be referred to. I intend to put the slide at the beginning. We're talking about insulin pump. First, we want to know what's the advantage and disadvantage of using insulin pump. So later on, when we talk about type of insulin, so we are aware of the advantages. There are plenty of advantages of using insulin pump, but mostly we can see that the improvement of a blood glucose and the reduction of hypoglycemia. So these two points really important, because we face it in the clinic. We face some challenges that when you control the blood glucose, you will end up having hypoglycemia. So each time when the patient comes to the clinic, we have to assess hypoglycemia awareness, because hypoglycemia awareness need to be there. If there is no hypoglycemia awareness for the patient, we have to understand that we can achieve the both with the insulin pump, with the help of insulin pump. I'm not saying that there are certain people with the good control, they are only using basal bolus, the injection, the MDI, but there are different people when they use the MDI, they will end up having more hypoglycemia. Some of the benefit, improve the quality of life, microboluses can be given, and what's the disadvantage is expensive, need to know carb count, apart from one insulin pump called islet bionic pancreas, which it doesn't need carb count, only you need the body weight, but it's not available in Saudi Arabia, and wearing the device most of the time. So there are many types of insulin pump, but mostly used in Saudi Arabia is these three types. One we call it Medtronic. This one I will show you I'm not sure of the pointer here. Okay, this is over there. It's Medtronic 780. It's integrated with the special sensors called Guardian 4. We're looking for a new sensor. It's called Simplera. It will be coming, inshallah, in a couple of months. Tandem or T-Slim. It's integrated with the Dexcom G6 and now G7 and Omnipod. The difference with the Omnipod is tubeless, whereas the Tandem and Medtronic has a tube on it. So both of them, or all of them, I would say, they are great. They're doing a great job. So these are some randomized control trial. I'm sure that some of us, or I'm one of you, that when you see a hectic or a busy slide, we don't want to read it all. We just want what's the summary of these trials. Well, ADAPT randomized control trial. They compare the people with the MDI, basal bolus, with the Medtronic 780. What's the conclusion? The conclusion that they see the time and range with those who use insulin pump 780 Medtronic superiorly or better in comparison with the MDI. On the other hand, there is another randomized control trial. This is for Tandem. Also, the results show a tremendous change in controlling blood glucose. So overall, insulin pump over the MDI or blood glucose or basal bolus for no doubt the insulin pump way better. So what about Omnipod? Is it better? It's also good as well. We can see that here's the timer range. It's better with those who use Omnipod. We can see that the hypoglycemia decrease with the using of Omnipod. The severe hypoglycemia decrease with the Omnipod. Also, the hyperglycemia increase. The hyperglycemia decrease with the using Omnipod. So in general, the insulin pump decrease the hypoglycemia and increase the time in range. Which is great to achieve that. So we know that from literature, the companies, they all talk about how good insulin pump. So what about the real life? This is one of our patients in the clinic. So we can see that he's using basal bolus insulin. We can see the timer ranges, but let's stop a while and say, like, what is timer range? You mentioned it many times. Well, timer range means that the blood glucose from 70 to 180. This is the ideal. The ideal, it should be 70 and above. This patient achieved the timer range. We're happy, but when you see the hypoglycemia, we're not happy. So we have to treat hypoglycemia. Sometimes when we relax the blood glucose, we end up having hyperglycemia. So when we shift the patient to insulin pump, guess what? The timer range increase, 87, and the hypoglycemia decrease. So achieving the two things at the same time, it's one of the great things that happen with the help of insulin pump. This is another patient. She used to be on MDI, and you can see that all her blood glucose above target. When we shift her to insulin pump, see, the timer range is 90%, which is one of the success story, I would say. So insulin pump, no doubt, it's great if it's available and affordable. Okay, so now we move to another option, which is smart insulin pen. Smart insulin pen, it's not as good as the insulin pump, but it's good. It's another option. It's cheaper. What it is exactly? This is the pen. You fill it with the rapid-acting insulin, but you need a basal, so don't forget the basal. While in the insulin pump, you don't need the basal. Only one type of insulin, which is rapid-acting insulin, whether it's Aspart or Lispro. But here, you need a basal. Okay, so what's the advantage of the smart pen? The smart pen is connected with the app, so and the sensor. So it gives a recommendation. So your blood glucose high, you need to take 4 units. Your blood glucose low, you have to eat something. So also the smart pen give a micro boluses. So even like half dose, I would say, half units. Sometimes with the regular insulin, we cannot give half the dose. So now we have the CGM, or continuous glucose monitoring, which is available in Saudi Arabia. We have many worldwide, but the one used in Saudi Arabia, we have the 3, CGM, continuous glucose monitoring. All of the 3 are good to show the blood glucose. These devices does not integrate or tell what the patient should do, but it tells what's the blood glucose right now. So if the blood glucose 200, it's 200 milligram per deciliter. So the small differences between the 3 of them, for example, Libri 2, we're waiting for Libri 3 Plus, inshallah, coming in a couple of months. Libri 2, it's been used for 14 days. The price 250 Riyal. Dexcom Dexcom 1 Plus, the price 180, but the duration is short, so 10 days. Sai, it's a new for the market. The duration is 14 days as well. The difference between them right now, the Dexcom can be weared in the arm, in the abdomen, in the upper buttocks, where in the Libri 2 and Sai in the arm. Okay, so now so when we mention CGM, we have to have a proof that it's good. Otherwise, we won't be using it. So there is a landmark trial called a Diamond trial. It shows that the CGM user achieve a blood glucose better than the home blood glucose monitoring. So this is another study which showed the hospital admission decrease with the one who using CGM. So when you think about it, it makes sense in it. I mean, like, if you know your blood glucose, you will act upon it. For example, if a patient eats a slice of bread and his blood glucose goes sky high, so next time he won't eat that kind of bread. He will eat half of it or he won't eat it. So those who know their blood glucose, they will act differently from those who doesn't know or they don't know about their blood glucose. So the results here, it makes sense that the user of CGM in controlling blood glucose and hypoglycemia better than the self blood glucose monitoring. Okay, and let's have a talk about, you mentioned that time and range. Why you didn't mention A1C? Well, in a couple of years, I would say, for the type 1 diabetes who using sensor, the A1C does not give a clear picture of the status of the blood glucose. For example, if you see the first pie, his blood glucose control, his A1C 7. If you see the second pie, his blood glucose quite control with the hypoglycemia 5%, the hyperglycemia 25%, and his A1C is 7. When you see this one, the hypoglycemia is 20% and the hyperglycemia is 40% and time and range only 40% and the A1C is 7. So all of the three, the A1C is the estimation. It's in the middle. It's given in the middle. For the type 1 on the basal bolus or any type 2 with the basal bolus, the fluctuation of a blood glucose, that doesn't give a clear picture of A1C. But we can use it. It's a good marker for now, especially for type 2, because the fluctuation is not that much. But with the type 1, the fluctuation is high. So the time and range would be accurate, more accurate to estimate the blood glucose. So now we finish with the technology, so let's have a brief touch about the new type of insulin. We know that rapid-acting insulin previously, there is an ultra-rapid acting insulin, which called Lemogif or Fayasab. Lemogif is Lispro and Fayasab is Aspart. So how good are they? Well, they did a study. So with the studies, we know that the efficacy of the medication. They compare the Lemogif, Lispro, rapid acting with the Lispro. So they see that the Lemogif no inferior than Lispro in form of preprandial blood glucose, but superior in postprandial blood glucose. Also, it makes sense, doesn't it? I mean, like the ultra rapid, it will act faster than the rapid, so it will act more on the postprandial blood glucose. So, which is great. This is the summary of a Brunto type 1 study and onset clinical trial as well done for the Fayasab. Lemogif is available in some market in Saudi Arabia, but Fayasab is still not available. Okay, this is an inhaled insulin. It's not new, but I brought this one just to remind us of or to give us about what's other option that we have. It's been approved by FDA 2014. It's way long, but unfortunately it's not available in Saudi Arabia. It's available as a monomerase regular of human insulin. Studies shows that inhaled insulin have a demonstrate faster onset and shorter duration compared with the rapid acting insulin. The use of inhaled insulin may result in a decline lung function. It's contraindicated in individual with the chronic lung disease such as asthma and chronic obstructive pulmonary diseases. These are studies that's an open-label randomized controlled trial crossover study. They compare the rapid-acting insulin with the inhaled insulin, which called Afrezza. So the results show that the Afrezza or inhaled insulin show that the peak is faster than the rapid-acting insulin, and the half-life is shorter. So it's a good option as well to keep it in mind. Okay, what about, we've heard that ultra-long acting insulin, it's called icodic or a weekly or once weekly long-acting insulin. Well, it's not yet been approved by FDA. It's the half-life is 196 hour. The onward trial, this is the trial done for this icodic. We can see that they compare it with the standard basal insulin. We can see that the estimated or the A1C reduction with the icodec, the weekly. It's better comparing to glargine or digludec, but the hyperglycemia is more with icodec. We can see that it's done in type 2 and type 2 and type 1. The type 1, it's up to now, it's not recommended to use it for type 1. Why? Because you can see the result. The reduction of A1C, it's worse than, or it's not superior than digludec, and the hypoglycemia, it's more. So we have to, up to now, it's not recommended for type 1, but for type 2, yes. Okay, denosinosyl or Lantidra. What is it? 2 years ago, the media was busy with this new achievement. Well, it's the first allogenic pancreatic islet cell therapy for the treatment of adults with type 1 diabetes with the severe hypoglycemia. They infuse the graft from the portal vein, and the patient need to be on immunosuppressive therapy lifelong. And but the issue with the Lantidra, the side effect, 90% of subjects had at least one serious reaction. The major cause attributed to liver laceration because it's injected through the portal vein, and it the graft settle in the liver. So hemorrhage, intra-abdominal bleeding, elevated portal pressure. From the immunosuppressive therapy, the infection is high. We account for 87%, whereas the malignancy also we have to pay attention to it with 37%. These are the clinical trial for the Lantidra. It's two clinical trial. The first study, which 10 patients, and the second study with 20, so the total is 30. They included all who receive at least one islet infusion and a maximum of 3 infusion. What's the result? We want it in a short term. Well, here's are the result of these trial. We can see that of the 3, 5 of them had no days of insulin independency. So that's mean the failure of the treatment. Whereas the 4% had the independent for less than for 1 year, whereas 12 subjects had from 1 year to 5 years, and 9 subjects achieved the success of the treatment more than 5 years. So we have to weight the benefit and risk of using this alternative medication. It shows the adverse event from using Lantidra. We can see that those, for example, 1, that's mean 1 side effect, 2 side effect, and 3. And we can see mild to moderate. We can see most of the patient has the side effect of using Lantidra. Mostly I try to make it as quick and short as possible, and thank you very much.
Thank you, Dr. Marzouk. يعطيك العافية. An excellent presentation updated about type 1 diabetes. Let's move to the next speaker, Dr. Faris Mtairi. Dr. Faris Mtairi is a senior internal medicine clinical pharmacist at King Saud Medical City. He has a PharmD graduate. He was a graduate from King Saud bin Abdulaziz University. He will present today tailoring obesity treatment in Saudi Arabia population, a challenging and opportunity. The floor is yours, Dr. Faris.
Thank you, Dr. Joseph, for introducing me. It's my pleasure to be here, and I would like to thank Dr. Ali Tbenawi and Dr. Hatem Harbi and the rest of organizing scientific and media committee for invitation. Today, inshallah, I'm going to talk about the tailoring obesity treatment for Saudi population, challenges and opportunities. Disclosure, nothing to disclose, and this is my key points that I will be addressed in the next 20 minutes. First, I will talk briefly about the overview of the obesity, discuss the current treatment for obesity, outline emerging therapy, and finally I will discuss the challenges and opportunities for the obesity. Obesity, simply defined as a result of long-term energy balance, where the energy intake exceeds the energy expenditure, which lead to accumulation of the adipose tissue to exist that impair both physical, psychosocial health, and well-being. It classified based on the body mass index to overweight of a BMI more than 25 to less than 30, and obesity start from BMI equal or more than 30 to less than 35. Obesity class 2 if it's more than 35, and class 3, and etc. Obesity is a global issue and a significant public health epidemic which have progressively worsened over the past 50 years. And has tripled globally since 1975. And according to the WHO, at year of 2022, 16% of the world population affected with obesity, which nearly around 890 million. And this number expected to increase to double to 1.5 billion by year of 2030. And around 7% of the mortality causes globally related to the obesity. Economically, its impact was estimated to be $1.9 trillion by year 2022, and with the projection reaching to $4 trillion by 2030. Also, regionally, it's highly prevalent, especially in the GCC countries, and there are 4 GCC countries are among top 20 of the most obese countries in the world. Unfortunately, KSA ranks 4th globally in the obesity rate, following Kuwait and Iraq and Qatar. And according to General Authority of Statistics, around 23.1% of our population affected with obesity, and the percentage of female exceed male. Moreover, there are similar cross-sectional studies across the KSA consistently confirm the high rate of obesity by different regions. And obesity consider significant economic and societal impact, including the cost of healthcare system. And the economic impact was estimated in the 2024 to be around $20 billion, and to be increased to more than 150 billion by year of 2060 in the Saudi Arabia. While obesity is important because it's related and responsible for developing new diseases such as diabetes, hypertension, dyslipidemia, heart disease, stroke, sleep apnea, and cancer, which lead to increasing mortality and morbidity, either due to obesity itself or obesity-related complication. There are multiple contributing factors, some of it non-modifiable, such as genetic and gender, whereas the lack of exercise and the food habit among the most modifiable risk factor. Also, some of psychiatric disorder and medication. I try to summarize in this table. There are multiple or numerous medications that induce a weight gain, and with the alternative. And I think medication is important to be assessed before starting anti-obesity medication, because all of this medication may interfere with the weight loss. Current obesity treatment, before we go to that, the available option or treatment, we have to understand the goal of a treatment, which is to prevent and treat complication of obesity, and to prevent further weight gain, reduce body weight, and try to maintain a lower body weight over the long term of time. This will end by improving the quality of life for those patients. The initial goal for weight loss is to achieve a healthier weight, and the healthier weight typically around 5 to 10% of the body weight. Why this weight is considered a healthier weight? Because it can be achieved for the most of the patient and safe, and it has less risk of weight regain, and around 0.5 to 1 pound loss per week. However, more weight loss is needed to translate into clinical improvement, especially in the diseases developed due to obesity, such as in the patient with hypertension, diabetes, and GERD. We need to increase the weight loss to up to 15% to see the improvement in such diseases, as well as dyslipidemia, obstructive sleep apnea, and asthma or COPD. I don't know why the numbers come in Arabic. This is the 5 A's framework, which is helpful before starting the obesity medication treatment. First of all, assess and confirm of diagnosis, then advise the patient about the risk and benefit to starting the obesity treatment. Then the most important thing to establish an agreement between the patient and healthcare provider in order to the weight loss goal, and the strategies, which medication suitable or procedure that he or she needed. Then assess, and don't forget a follow-up. This is the 3 pillars of obesity treatment. Firstly, we can start lifestyle alone in any overweight patient. Has BMI 25 or more. And patient needed to start an anti-obesity medication. It can be started if the BMI equal or more than 30 or more than 27 with any obesity-related complication, and surgery reserved for patient with high or obesity class 3 BMI more than 40 or more than 35 with at least 1 or more obesity-related complication. Lifestyle can be comprehensive, including dietary therapy, exercise, behavioral modification by modifying and monitoring the food intake, modifying the physical activity, and controlling the causes and stimuli in the environment, especially that will trigger the food. And I think it's a cornerstone for the lifestyle modification. Before we go to the current FDA-approved anti-obesity medication, we can go back to the historical medication. The first one was methamphetamine, and its derivative fenfluramine and dexfenfluramine, then phenetramine, orlistat, and leucoserine. And leucoserine withdrawn from the market in the 2022 due to risk of cancer. And nowadays we have 6 medication, orlistat, and 2 combination, phenetramine, topiramate, bupropion, naltrexone, and in the 2014 liraglutide, which is GLP-1 introduced to the market, then semaglutide, and in the last year tirzepatide. This table just summarizes dosing and route of administration, side effect, and contraindication. I want to just to highlight on the weight reduction. It can be with the phenetramine topiramate. It can reduce the weight from a baseline up to 11%, and weight loss with naltrexone bupropion to up to 6%. With the liraglutide, we may reach to 7%. With the semaglutide, we can reach to 14.9%. Tirzepatide, we can reach up to 20.5%, and with the orlistat, only 3.4%. The current anti-obesity pipeline, we have around 157 clinical stages of the medication, including 7 only in the phase 3, and the other either in the phase 2 or phase 1 or still in the pre-clinical, which has more than 60 different mechanisms of action, and only 43% of them were orally, where the other either parenteral or topical. And the main point, our primary outcome, is focus in enhancing the weight loss by combining different gut hormone or different mechanism of action, and to improve the dosage form, such as the oral dosage form, and to offer a less frequent dosing, such as once monthly versus once weekly or daily. This table just summarizes the medication, some of it in the phase 3, the other in the phase 2. I want to just to highlight in the mechanism of action, if you can see, and route of administration, we have semaglutide. The approved form now is injectable. However, semaglutide orally ongoing now, and orforglipron also can be given orally. And cagrilintide work by different mechanism of action on the amylin receptor. And we have 4 medication combine GLP-1 and glucagon receptor, such as survodutide and mazidotide, bemfidotide, and retatrutide, which is the first medication work by different mechanism of action. It can targeted GLP-1, GIP, and glucagon receptor. So we may have more weight loss since integrate more than 3 gut hormone. And cagrisema, which is combination of cagrilintide with semaglutide, also ongoing now. The weight reduction achieved, highest weight reduction achieved with retatrutide, because it works with different mechanism of action. It can work by 3 receptors, up to 24.2% achieved the weight loss, and followed by 22.5% with tirzepatide, and survodutide achieved 18.7%. Not only this, weight reduction, after a follow-up, there are the patient achieved more than 50% weight reduction from the baseline, around 82% in patient with retatrutide, and compared to only 78 patient with tirzepatide group. However, this is in regard of safety. However, regarding the safety, side effect is still the same, and sometimes it gets worse and reach up to 36%, such as nausea, vomiting, and diarrhea, and sometimes constipation. This is the emerging anti-obesity medication which can be given once monthly. We have now a medication called maritide, work by GIP-1 receptor antagonist and GLP-1 agonist. This is opposite to the tirzepatide. It can be given once monthly, and still in the dose of 280 milligram once monthly, achieved till now 20% weight reduction from the baseline. And we have another medication which can work by different mechanism of action, which is monoclonal antibodies. Bimagrumab work by stimulating skeletal muscle growth by blocking activin type 2 receptor. It can be given also once monthly. And this medication not only reduce or cause weight loss, it can reduce a total body fat mass by around 7.5 kg, and also increasing lean body mass by 3.6%. And we also have 2 other medication ongoing, which targeting the monoclonal antibodies for treating obesity patient. With the presence of all the medication, either approved or still in the ongoing, still the obese patient faced a lot of challenges and lack of opportunities. And it can be broken down into either patient-related, community-related, policy-related, or physician or healthcare provider-related. In regard to patient, food habit, lack of recognition of obesity as a chronic disease and relapsing disease, may يعني come late to the clinic to seek intervention, insufficient knowledge about the medication, especially side effect, and failure in maintaining the weight loss and unfortunately loss of follow-up in the long term. Community responsible for increasing the awareness, eliminate the weight stigma, and improve the public health messaging around the obesity and the maintenance of health lifestyle. And I want to highlight 8 programs which our strategy which published and still now by different agency to help the patient to enhance engage more in the physical activity and to reduce obesity. And the quality of life program launched by Vision Realization Office as a part of Vision 2030, which aims to reduce obesity prevalence by 3% and increasing physical activity at least to up to 40%. The policy responsible for the cost of medication, as you know, most of the medication higher in the cost, and some of the patient cannot afford the medication because of the restriction, and access to the treatment may be not available due to a proper restriction, and can be overcome by encouraging the insurance companies to cover the full range of obesity treatment, and update national obesity guideline. Regarding the healthcare provided, recognize obesity as a chronic disease, not just a risk factor for all other disease. Increase the health care professional education guideline and resources, and establish a clear referral pathway from a primary to a tertiary center for patient looking for obesity management. By this, I end my talk. Thank you for your active listening.
Thank you, Dr. Faris, for your nice, informative presentation. Just to remind the audience, any question will be postponed to the panel discussion after our speakers' talk. The next talk will be with Dr. Bashriya Shammeri. She will present about diagnosis and management of X-linked hypophosphatemia. The floor is yours, Dr. Bashriya.
السلام عليكم ورحمة الله. Today I will talk about the diagnosis and management of X-linked hypophosphatemic ricket. I have nothing for disclosure, and this is my objective. First I will talk about hypophosphatemic ricket pathophysiology, then we'll go through X-linked hypophosphatemia mechanism, clinical and biochemical manifestation, then management. And we will discuss the challenges in conventional treatment and overview of the updated treatment modality. Hypophosphatemic ricket represent impaired bone mineralization due to phosphorus deficiency. As you know, phosphorus is the key regulator of the bone mineralization and the growth pellet apoptosis. Those two aspects, any defect of these two aspects will cause ricket with normal calcium and parathyroid hormone. Most children and adolescents have a genetic cause, while acquired causes are seen in some older children and adolescents. Hypophosphatemic ricket either FGF23 dependent, like MFX gene defect or mesenchymal tumors, or FGF independent, like renal phosphorus wasting and MBT2 defect or dent disease. What is X-linked hypophosphatemia? It is lifelong, rare, genetic, chronic, and progressive musculoskeletal disorders that characterized by renal phosphate wasting. It's affected approximately 1 in 20,000 individuals in lifelong condition, caused by mutation in MFX gene leading to excess serum fibroblast growth factor 23. It is have different phenotypic manifestation with numerous clinical manifestations that may present in a lifespan of individuals. And X-linked hypophosphatemia is the most common form of inheritable hypophosphatemic rickets. It affects phosphate homeostasis. If FX gene mutated lead to increased FGF23, then will affect active form of vitamin D secretion and decrease phosphate absorption in the gut. Also, it will decrease sodium phosphate co-transporter, which lead to decrease in phosphate reabsorption in the kidney and therefore phosphorus wasting in the urine, which end with decreased serum phosphate level and hypophosphatemic ricket, which lead to stimulation and musculoskeletal consequences. It is inherited as X-linked, so if the father affected, he will transmit the disease for all his daughter, and if the mother affected, she will transmit to only 50% of her children, regardless of the sex. And the majority of the cases diagnosed with fixed gene mutation are inherited, while there is 20 or 30% diagnosed with de novo mutation, and for those cases, we need genetic analysis. In children, diagnosis of X-linked hypophosphatemia depend on the presence of a clinical, biochemical, radiological evidence of ricket with low phosphorus in the serum and renal phosphorus wasting, vitamin D and calcium deficiency. In adults, same, plus the more lower limb deformity and more worsening clinical and radiological image. This image shows ricket features. As you see on your left side, this is a ricket and osteomalacia in the knee, and then in down picture, this is teeth abscess, and then bowing leg of the lower limbs, bowing of the lower limbs, and decreased growth velocity in children. This is a study done by Shahad bin Abbas and et al. To searching for dental manifestation of X-linked hypophosphatemic ricket in Saudi Arabia. As you see, most common feature is enamel hypoplasia and dyschromia. Some patients will have spontaneous fistula. This is another study searching for articular manifestation of X-linked hypophosphatemic ricket in Saudi Arabia. As you see, the most common feature is geniovarium, representing more than 60% of the patient, then bowing of the tibia only, then geniovalgum and craniosynesthesis and coxavara. To diagnose the patient, we need detailed history, focusing on family history, drug history, and dietary history. And we need to evaluate the patient clinically, searching for sign of ricket, dental abnormality, deafness, hearing loss, or craniosynostosis. Also, we need biochemical tests other than bone profile. We need to do urine test for tubular maximum resorption of the phosphorus per glomerular filtration rate and urinary calcium creatinine ratio. Along with high FGF23 and urine dipstick to rule out Fanconi syndrome. This is the normal phosphorus range. Also, we need radiological evidence of severe ricket and renal ultrasound. To confirm that, we need genetic analysis for fixed gene and for the family counseling. This is an article published by Gulf Cooperation Counseling for diagnosis and measurement of X-linked hypophosphatemic in children and adolescents, which is summarized in this picture. And the most important part of this talk is therapeutic management, because before 2018, we have only conventional treatment. After that, we have additional treatment which help to improve the quality of life of those patients. Conventional treatment, I mean oral active vitamin D and oral phosphorus, which help to promote growth and correct leg deformity and facilitate tooth mineralization. However, there is 20 to 40% of the patient still show a linear growth failure despite optimal treatment and have final height under 2 standard deviation below the mean. To improve outcome, the children should diagnose and treat it as early as possible, despite these less efficacy. Also, conventional therapy have many side effects, and rigorous dose scheduling lead to compliance issue, especially phosphorus need to be given 4 to 6 times daily, which need to disturb the child's sleep, and it has bad taste. So it is, most of the patients had poor adherence for this reason. And the risk of long-term therapy include hypercalcemia, hypercalciuria, nephrolithiasis, nephrocalcinosis, and hyperparathyroidism. This is study done in also Arab countries by Asma Deeb and Itals to study the awareness and knowledge and practice of pediatric endocrinologists, and they found the same challenges, which is poor compliance, lack of accessibility to medicine, reduced final height, and inability to reverse skeletal deformity, and nephrocalcinosis, which is account for a quarter of the patient, and hyperparathyroidism. Why there is no benefit? Because they don't target the pathophysiology of XLH. And also because 20 to 40% of the patients with well-controlled XLH, well-controlled medication show a linear growth failure despite optimal treatment with conventional therapy. So moving to other line of treatment, which is Pruzamab. It is recent or new medication is approved by US FDA in 2018. It is represent paradigm shift in the treatment by targeting the pathology of XLH. And it's a disease-modifying therapy that restores phosphate homeostasis, and it is designed to bind and inhibit FGF23. It is available in all GCC countries for X-linked hypophosphatemia, for adult and pediatric from age of 6 months of age and older, and for those with a tumor-induced osteomalacia caused by FGF23 gene, and it's for adult and children more than 2 years old. There's a lot of clinical trials studying safety and efficacy, but I will start with this randomized controlled trial. This is compare Pruzamab with continuation of conventional therapy in children with XLH disease. They study children in age 1 to 12 years old. They measure total RSS and should be more than or equal to, and they confirm there is a PEX gene mutation. Also need to measure the fasting phosphate and need to be low in these cases. They compare 2 groups of medication with Pruzamab, 0.8 milligram per kg sub-Q injection every 2 weeks compared with oral phosphate and active vitamin D. Primary endpoint, they study RGI-C global score, which is represent radiological global impression of a change at week 40 of medication. That means change from the baseline in rickets severity. Selected secondary endpoint, they assess rickets severity score at at week 40 to 64, and serum alkaline phosphatase, and recombinant length standing hides the score with fasting serum phosphorus, all bone profile along with tuberous maximum phosphate, reabsorption over GFR, and 6 hours, 6 minute weight challenge test for children more than or equal 5 years old. For the safety, they assess the number of participants with adverse event and serum calcium and plasma intact parathyroid hormone. Also 24 hours urine calcium excretion and 24 hours urine phosphorus creatinine ratio. For the efficacy, they found that Prozamab treatment demonstrated significantly greater improvement in RGIC global score than conventional treatment at week 40, which were maintained through the week 64. As you see, Prozamab and the blue line reach substantial healing, which is +2, compared to the conventional therapy, which didn't pass +1. Other effect is total score of rickets scoring severity. Prozamab significantly decreased the ricket scoring severity compared with conventional treatment at week 40 and 64. Also, there is a change in serum phosphorus level from the baseline were significantly greater in the Prozamab group than in conventional therapy group through the study. Especially started from the week 2. The improvement. Changing in the tubular maximum phosphate over GFR ratio from the baseline were statistically significant, greater in the Prozamab group than in conventional therapy. Also, Prozamab treatment significantly improved in disease walking at 64, and distant walking at 64 compared with conventional therapy. Safety result studied in many articles and many studies. All the studies show same what I mentioned before. Conventional therapy has more severe side effects like first GI symptoms, nausea, vomiting, and abdominal pain, and second nephrocalcinosis, nephrolithiasis, and hyperparathyroidism. While Prozamab show only minimal injection pain, which is improved at the same day. And it happened once every 2 weeks only. So to summarize this study is the first trial to compare conventional therapy and Prozamab in the children with XLH. Switching from conventional therapy to the Prozamab significantly improved the ricket, leg deformity, and phosphate metabolism in children aged from 1 to 12 years with XLH. By inhibiting increasing in FGF23 activity and normalizing urine phosphate excretion, Prozamab induced the clinical improvement within 64 weeks and has potential to prevent a long-term complication. This study and other demonstrated of the Prozamab over the conventional therapy. The dose recommendation by US FDA for pediatric age group started from 6-month-old to less than 18 years. It is given from 0.8 to 1 milligram per kg every 2 weeks, subcutaneous injection, to maximum dose of 90. For adult, they recommend starting dose 1 milligram per kg. It is every 4 weeks with maximum dose 90. During the treatment, they need to do serum fasting phosphate, should be monitoring every 4 weeks at the first 3 months of treatment, and then with each dose adjustment. This is another case series published last year in assisting 14 patients with XLH from Gulf Cooperation Council countries from Saudi Arabia, Kuwait, and United Arab Emirates. Those patients aged from 2 to 40 years at diagnosis. All the 14 patients started on conventional therapy for 1 year, and then 10 of them shifted to Prozamab treatment. The case series study show conventional therapy resulting in suboptimal response with lack of improvement in clinical signs and symptoms. Side effects of conventional therapy include nausea, diarrhea, abdominal pain, nephrocalcinosis, hyperparathyroidism, which affect the patient's quality of life. and adherence of the treatment. Bruzumab demonstrates marked improvement in the biochemical markers of rickets, in addition to reducing pain and muscle weakness and fatigability. There is no significant side effect except localized pain from the injection site. So in conclusion, XLH poses substantial burden of the lives of the patient suffering from the condition from childhood to adulthood. Conventional therapy remains challenging due to the persistence of the symptoms and unpleasant side effects, which can lead to the poor adherence. And the bruzumab treatment improve benefit, bone health, and patient symptoms and quality of life. That's it, and thank you.
رؤية المملكة 2030 رؤية طموحة تقودنا نحو مستقبل أكثر إشراقاً، تولد إنجازات وتحيي روح الابتكار والاستقلال الصناعي. اليوم نشهد إنجازاً تاريخياً غير مسبوق، وضع حجر الأساس لمشروع إنتاج وتصنيع أقلام الإنسولين محلياً لأول مرة في المملكة العربية السعودية، إنجاز يحمل توقيع أول اتفاقية من نوعها في المملكة، وثمرة شراكة استراتيجية بين نوبكو وشركة سانوفي الفرنسية وشركة سودير فارما بدعم من هيئة المحتوى المحلي والمشتريات الحكومية، لتصبح المملكة منارة في الابتكار الطبي والإنتاج المحلي. مشروع إنتاج أقلام الإنسولين ليس مجرد مبادرة صناعية، بل هو رؤية تتحقق وأثر يحدث تغييراً جذرياً في منظومة الصحة والاقتصاد الوطني، مع منتجات عالمية رائدة مثل لانتوس وتوجيو. نؤكد التزامنا بتوفير حلول طبية محلية بشراكات وخبرات عالمية ترتقي إلى أعلى معايير الجودة العالمية. هذه المنتجات ستساعد على سد احتياجات مرضى السكري ورمز الاعتماد على الذات بالمملكة العربية السعودية وتحقيق الأمن الدوائي. الأرقام تخبرنا بحجم التأثير الهائل لهذا المشروع، أكثر من 15 مليون قلم إنسولين سنوياً. هذه الكمية الهائلة ستساهم في تأمين العلاج لأكثر من نصف مليون مريض سكري سنوياً، و70% من مرضى السكري المستخدمين للأنسولين في المملكة. وسيكون للمشروع أثر إيجابي كبير على الاقتصاد الوطني. إنتاج أقلام الإنسولين في المملكة العربية السعودية يمثل أكثر من مجرد إنجاز صناعي، بل هو رسالة واضحة لما نقدمه جميعا في خدمة متميزة للمرضى. اليوم نحتفل بهذا النجاح الذي يجسد رؤية المملكة الطموحة، مؤكدين أن المستقبل لا يعرف حدودا. معا نمضي نحو مستقبل يتسم بالقوة، الابتكار والاستدامة، ليظل اسم المملكة العربية السعودية رمزا للتقدم والريادة. تعهدنا في شركة سودير للأدوية بالمساهمة في بناء مستقبل الصناعة الدوائية المتخصصة بالمملكة العربية لنزرع الأمل بالشفاء.
So supposed to be applied this rule. Consequently, marriage 57.7 in Saudi Arabia, 28.4 first degree in marriage, second degree in marriage 16.4, and distal around 2.5. So these my facts, and I supposed to be everybody knows. So the main issue here for familial hypercholesterolemia, there is still very close 57.7 consequently here in Saudi Arabia. Second one of the very famous studies, which is Race and Inter-Heart study. The first presentation of acute MI in Gulf country is 10 to 12 years early than Western country. On the other hand, homozygous familial hypercholesterolemia is the same privilege as if it's Western country. First statement is correct while second is wrong. First statement is wrong while second is correct or both wrong. Very important, right? Next. I think this is a picture of classical patient of homozygous familial hypercholesterolemia. My concern, everybody knows, but for cardiologists, the issue is totally different. The problem of aortic root, it is not simple aortic root stenosis. The problem, cardiologist is here. So the issue is annular mechanism and the subannular mechanism more than issue of aortic stenosis alone. So if anybody handling patient with homozygous familial hypercholesterolemia, most of them, the not issue of remove the AVR, make it AVR, no. The issue it is remove the valve and remove the subvalvular mechanism. So the issue is totally different than simple aortic stenosis. Nicely. Here, peripheral arterial disease is the first adverse cardiovascular event in patient with homozygous familial hypercholesterolemia. Anybody say yes or no? Peripheral arterial disease is important and the first adverse cardiovascular event in patient with homozygous familial hypercholesterolemia or no? Somebody is laughing. This again is important. Response of lower lipiding therapy like statin, azetamide, BCK9 inhibitor, in general, dyslipidemic patient is the same as homozygous familial hypercholesterolemia. Yes or no? No, perfectly. In 2023 guideline, the high risk of atherosclerotic cardiovascular pathology, the target is less than 70 or less than, as if you can see here. This is concerning always even cardiologists, the thinking is less than 40 is mostly optimum in our patient. It is not the issue of we can make it tightly controlled, but we like as a cardiologist is LDL, it is not go to the one only, or maybe less. Fine. Here, for cardiologists and non-cardiologists, please put it your stethoscope in the chest. Don't say I am lipidologist. It is very nicely to be very commonly to appreciate the crescendo murmur if you put it your stethoscope here. I don't know why everybody is now put it a stethoscope in his back. It's very nice. So crescendo murmur, ask our cardiologist. You can see very early. This murmur, it is not simple murmur of valvular aortic stenosis. I think cardiologists know what I mean. Lastly here, do you think there is need of psychiatrist or psychologist in patient with familial hypercholesterolemia clinic? Do you think this is important? Nicely. Very good. This first case you can see very nicely here. This is my patient, by the way. 34 years old male, non-case of homozygous familial hypercholesterolemia, post-stenting, post-BCI, session in 2024, and then he go for recent MI, recent cabbage time 4, and he came for your clinic for routine follow-up. His LED still is sky high, 10. He was already in high dose of statin therapy, and this patient in azetamide therapy, and he is in Repassa. And this patient have, you can see here, 140 milligram, So what you can see, to leave this patient alone or double the dose of PCSK9 inhibitor, or this patient, can you start some fancy medication, which is MATP inhibitors? Still, the picture is vague. So I can make it simple now. Homozygous familial hypercholesterolemia, now it is life-threatening people. So if you leave them untreated, the patient can die at any time, even very, very early. The second important thing here, everybody knows how the familial hypercholesterolemia kill our heart. The patient of homozygous familial hypercholesterolemia, always the symptom is coming very early, when the age may be 12, in compared to the patient with heterozygous, which you can start it, as you can see here, 35 in compared to the other people. Anybody knows this place, Mahdi Dahab? Anybody visit Mahdi Dahab? I visit by myself. Most of the patients there is very close to each other. كلهم متجوزين من بعض. The chairman, I'll say yes. Right? So this is the main concern. This is the main concern. That's why familial hypercholesterolemia is very, very high in their place. And you can see here the consanguinity, it is 57.3. You can see very high, very high. And the issue here is 1 to 1.2, even in Qatar and Bahrain. Definitely everybody knows what's our level now. But my concern, please go to beyond our level, especially in high-risk patients. So in patients with familial hypercholesterolemia, we are not consider our level as if the patient is non-homozygous familial hypercholesterolemia. So our target here, not the usual our target. Our target here, you can go beyond the reality. The reality. Our colleagues make very simple way to make it simple issue. Here, if the patient is homozygous familial hypercholesterolemia, and he takes the medication very well, and after that, the patient is not reaching the target. You can see here, the patient of LDL, 1.5. I want to see something important here. Don't continue by the medication which is already failed to make it. This is my concern alwaysly. So if you try to use the patient of PCSK9 inhibitors for only 2 to 3 weeks, not will go beyond, and no benefit, please stop the medication then. This is a guideline. Agree or not? This is a guideline. So I saw most of our patients, he's still in PCSK9 inhibitor at 2 years, 3 years. 2 years and 3 years, and the patient is still in the target. 3 years, and the patient is still in the target. Fine. These very important slides. Why? In order to, we need to say something here. There is medication which is rely in receptor, and other medication, it is not rely in receptor. So, for example, statin therapy, for example, if patient is relying on LDL receptor, it can decrease the LDL maybe around 25, azetamide around 20. PCSK9 therapy, it may be, you can see here, maybe 0 if no LDL receptor, right or no? Or maybe it is go up to 20, 25. But this other category is not rely on receptor. That's why we say widely for everybody, use the clinic of lipids. Please don't go by PCSK9 inhibitor if he fail in front of you. Right or no? So we need to make it for this fancy medication. Why? In order to this, not rely on the LDL receptor. Right? This is exactly what selabutamide act. Act in two ways. Liver cell pathway and the intestinal pathway. In lipid pathway, it is kill the arm of very low density lipoprotein. In intestinal way, it is kill what you can say chylomacron. So the end of the day, no any harm LDL go to our circulation. It's not rely on receptor. This is exactly what medication is. We start by 5 and 20, and in my clinic alone, we have family. I don't have patient by patient. I have family, 4 of these family in the medication. So it is classical homozygous familial hypercholesterolemia. Most of these patients MI at 13 years old. He's MI'd. And then after that, he make coronary artery bypass surgery, but not simple coronary artery bypass surgery. He make a sternotomy simply, and then he remove the aortic valve and remove all the root due to atherosclerotic, which is called Bintal surgery, which is very difficult to be used. Cardiologists know what I mean. Fine. Here, this phase 3 trial to say something important about design is this very good study. Why? In order that it is continue in lobetomide therapy, start by 5, end by 60, and then go through to long-term extension, and the extension now beyond the 5 years. You can see here, started from here and end by this one, and the end result, what you can say, 1 to 6 weeks, 1 to 6 weeks. And there's a finding. The LDL dramatically decreased, as if you want to see, maybe they're more than 50%. And again, it is continue be decreased to the end of the study, which is cross 50 week now. Lastly, the side effect, everybody knows about side effect, which is mainly GI. And the lipidologists know how to deal with this subject. Second important thing here, more than 65% reduction in LDL level with lobetomide from data from Italy. You can see here, more sky-high LDL, your medication is become more perfect. Lobetomide average dose here is 19, not the maximum dose. Another study here from Europe is exactly approximately the same. They mentioned very nicely, if you go by lobetomide therapy, more than 50% reduction of LDL. This LDL, again, for lobetomide therapy, is decreasing from 68.2, and if it is from baseline to last visit, and from patient to nadir is 66.5. Lastly, in the 9 data, which is came fully, they say most of the patient which is go for, I say by big bows, it is against dialysis. Patient of apheresis is like dialysis. So it is very hard to see this picture in order to, even if it is available in the very flow, and if the straight is maybe from Riyadh only. But I'm very ashamed to see patient make a transplantation. I can say more than transplantation. So LDL again, apheresis, as if you can see, it is very hectic, and it is not reaches the patient from baseline to down, which is very harming the patients. Homozygous familial hypercholesterolemia review here, again, it is more than 50%, and this from local, from our colleague, Dr. Hawazen. Second thing, you can make it easy. It is not issue now, is decade. And the Saudi FDA, it has approved it from 2021 till now. And we have a lot of patients now. Dr. Fakhra knows more than me. Fine. I will answer my tips and tricks very quickly. We think the time came, so from now on you can see most of the newly married patients, they will not go except to will make the pre-material test for familial hypercholesterolemia. Second thing, all of our Gulf area, it is consistent with internationally and the MI, but we can say, it is not like hand of homozygous familial hypercholesterolemia in the same privilege. So the first statement is correct, while the second is totally wrong. Second thing is, this picture is classical, but I want to inform you, if you see this patient in your clinic, please, his LED is more than 10. So don't wait till this tragic effect. Peripheral arterial disease is now. The first important coming alwaysly is angiogram, maybe, and this angio. You can see here, it's important for everybody. Alwaysly MI coming early. Peripheral arterial disease is coming very late. So if your patient If your patient coming to you by advanced peripheral artery disease and he's young, please consider familial hypercholesterolemia. Response of lower lipiding therapy in patients with homozygous familial hypercholesterolemia approximately the same? Definitely is no. You can see here. The patients with statin therapy, even high-intensity statin therapy, is go by less than 10% or 25% max in the patient with homozygous familial hypercholesterolemia. Patient with bile acid, it is only 10%. Absorption inhibitor, 10%. Nicotinic acid, again 10%. BCK9 is maybe around 20 to 30%. So the 2023 guideline, they mention that our target in extremely high-risk patient, it is not less than 55 as if everybody knows. No, less. It's less than 40, meaning 1 milligram. This is our cardiologist guideline. Second thing, it is very commonly for familial hypercholesterolemia to appreciate crescendo-decrescendo members is very nicely, and it is important for even non-cardiologists. Put it your stethoscope here, please. Lastly, do you think there is need for psychiatrists? Definitely yes. So anybody wanted to open lipid clinic or FH clinic like us, so please try to invite some of our colleagues from psychiatrists. This is our case presentation. So my concern for this presentation, don't go more and give a chance to BCK9 if they fail from the day one. This is my concern. And this, I think it has become a little bit okay. And thank you very much.
شكرا دكتور أيمن for your attractive presentation really. Let's move to the next speaker with Dr. Mohammed Ahmed al-Rashidi. He will talk about updates on the management of type 2 diabetes mellitus. Dr. Mohammed al-Rashidi is cardiology clinical pharmacist in Al-Noor Hospital in Mecca. تفضل دكتور محمد.
السلام عليكم ورحمة الله وبركاته. في البداية حاب أشكر الزملاء بتجمع صحيح حائل على الدعوة الكريمة والانضمام إلى كوكبة من الزملاء في الصيدلة الكلينيكية في تقديم الجلسات العلمية. طيب. Today I'm going to talk about the updated management of type 2 diabetes guideline. This is my disclosure. Objective for my presentation will be overview of diabetes mellitus and the prevalence of epidemiological statistics in the Kingdom of Saudi Arabia. Then there will be overview for pharmacological recommendation and last updated guideline in 2025. Then there will be overview for landmark trial for heart failure and chronic kidney disease in patients with type 2 diabetes mellitus. As we know, the diabetes mellitus is one of the leading cause of mortality and morbidity in the world and in the Kingdom of Saudi Arabia, and the Kingdom is ranking among the top 10 countries globally in the term of diabetes mellitus, and the prevalence it's projected to be among the top of 5 countries for type 2 diabetes by 2030. As the national prevalence study in the 2023, the national prevalence diabetes among the adults reached up to 32.8%, significantly increased from 30% in 2013. The prevalence is high among the male more than female patient. According to the national prevalence for high risk factor for patients with type 2 diabetes mellitus, overweight is ranking the first cause, one of the risk factor, followed by physical inactivity and obesity. According to the general statistical from Authority of Statistics, for the city of high prevalence of type 2 diabetes, unfortunately it's Mecca city, followed by the Ha'il city is ranking the top 2 cities in the kingdom for high prevalence of diabetes mellitus, followed by the Najran city. According to the prevalence and epidemiological study, they are increasing the incidence of diabetes with the increasing age and reaching to the maximum at the age of 65 years. For screening of type 2 diabetes mellitus, according to the clinical practice guideline from Saudi, the screening should be for all according to the epidemiological evidence for the risk factor of type 2 diabetes, the obesity and sedentary life. It's cost effective to screen all population above the age of 35, and repeating of testing of the patient level is normal after 3 years, and the patient with pre-diabetes should be tested yearly. Women with a history of gestational diabetes should be tested for every 3 years lifelong. The most common diagnostic test used for patients with type 2 diabetes, there are several ways for diagnosis of type 2 diabetes, which including the hemoglobin A1C, fasting blood glucose, 2-hour glucose random glucose level for the patient with hyperglycemic symptoms. It's very important to know the limitation for hemoglobin A1C concentration. If the patient have any cause for red blood cells turnover, for example, patient with anemia and patient with CKD and pregnancy, and patient use of medication, for example, ESA or erythropoietin stimulating agent, the accuracy of AC will be low, and the guideline is recommended to use alternative measure, for example, ferroctazamine. For approaching for individualization of glycemic control in patient with type 2 diabetes, the guideline is recommended to be strict the control for patient with the low comorbidity, patient younger age to be less than 6.5, for the patient with the healthy adult with some comorbidities or cardiovascular morbidity, the A1C should be less than 7. For adult patient with complex comorbidity or intermediate health, the guideline recommendation to targeting A1C less than 8. For pharmacological approach for management of patient with type 2 diabetes mellitus, always we ask the questions when we can start the injectable medication for patient with type 2 diabetes mellitus. The guideline gives preferred for GLP-1 receptor agonist to be started because its ability to achieve both glycemic control, weight management, and the patient low risk of hypoglycemia if patient started on GLP-2 receptor agonist. For patient when to start the insulin, injectable insulin for the patient with type 2 diabetes, the guideline is recommended to be started if there is evidence for catabolism or unexpected body weight loss, A1C more than 10% above the targeting level. For the combination of GLP-1 with the insulin, the guideline is recommended we can use, but the dose of insulin needs to be adjusted to reduce the risk of hypoglycemia. For general consideration, to be when patient will start in glucose-lowering therapy, the guideline is recommended to select the most effective medication that reduce A1C, and the safety for the medication that will reduce the risk of hypoglycemia and reduce for weight gain, cardiovascular and renal benefit, conventional for low side effect, administration route and dose frequency. Durable, low risk of secondary failure, and affordable. Due to in the 2018, the FDA revised for the new regulation for for medication for type 2 diabetes mellitus, that all patients should be undergoing long-term cardiovascular outcome trial in addition to providing glycemic efficacy. After this regulation, new medication for lower glucose lowering therapy classes like DPP-4 for example sitagliptin, saxagliptin, and GLP-1 receptor agonist SGLT2 are become available and established in the treatment of type 2 diabetes mellitus. For the guideline recommendation how to start the medication, they divide the patient into two groups according to the several factor and patient preference and the condition. For patient with diabetes mellitus without any comorbidities, the guideline recommend to start weight management medication with the high efficacy, for example, like semaglutide or tirzepatide, and patient with ASVD cardiovascular risk or patient with heart failure or chronic kidney disease, the guideline is recommended to start GLP-1 receptor agonist with proven cardiovascular benefit of the patient. Diabetes mellitus with heart failure, the guideline is recommended to start SGLT2 inhibitor with the proven benefit in this population And the patient with CKD, the guideline is recommended to start the maximum first to patient to be in maximum tolerated ACE inhibitor or ARBs, followed by started SGLT2 inhibitor for the patient with the CKD and EGFR more than 20, and to be continue until the patient to be transplant or patient starting dialysis. Now we'll be moved for the landmark trial for cardiovascular benefit in patients with in current management of type 2 diabetes mellitus. All of this trial was compared with the placebo and examined for the reduce of MACE in patients with type 2 diabetes. We'll be go through this trial. Will be started with GLP-1 receptor agonist, semaglutide, and cardiovascular outcome in patients with type 2 diabetes. Sustained trial. This trial will include 3,200 patients with type 2 diabetes and A1C more than 7%. Divide the patient into 4 groups. Patient will be received semaglutide 0.5 weekly, and the other group will be received semaglutide 1 milligram weekly. The other placebo group will be received same dose. The primary outcome is composite of measure of MACE for cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. The result of sustained trial was showing the primary composite 8-point was low in patient with semaglutide group versus placebo, and the non-fatal stroke and the non-fatal MI was statistically significant in semaglutide group versus placebo group. Other trial, it's REWAND trial, which in this trial, dulaglutide was used in patients with type 2 diabetes and to reduce the risk of incidence of MACE. The total population around 10,000 patients. The intervention in this group was dulaglutide 1.5 milligram once daily versus placebo in addition to standard of care. The composite endpoint for cardiovascular outcome was low in patients in dulaglutide group versus placebo group. What's about SGLT2 inhibitor? There is a lot of trial for SGLT2 inhibitor for patients with type 2 diabetes. This the first 2 trial was empagliflozin or EMPA-REG trial was showing the incidence of MACE is low in patient with type 2 diabetes by around 14%, and cardiovascular death from any causes was very low in patient with the empagliflozin versus placebo by around 30%. For patients in canagliflozin, the MACE was reduced by around also 14%. And this trial also was compared the use of empagliflozin in patients with the heart failure with or without diabetes mellitus. And this trial divided the patient into 2 groups, empagliflozin 10 milligram, and the other group will be received placebo and will follow up during the study period for around 4 years. The primary outcome was composite of cardiovascular death or hospitalization for heart failure. In this trial, the effect of empagliflozin in combined risk factor cardiovascular risk death or hospitalization in patients with volume overload or without volume overload, the empagliflozin was statistically significant, low incidence of MACE more than placebo. And in this, and also for hospitalization for heart failure, the empagliflozin showing statistically significant lower risk for hospitalization when compared with the placebo. What's about DDB4? We have 4 market trial, allogliptin, sitagliptin, and sitagliptin and linaglutide. For both sitagliptin and linaglutide, they have natural effect in patients with cardiovascular effect and doesn't decrease MACE. For 2 groups, for 2 other medications, sitagliptin and allogliptin, will increase the incidence of heart failure hospitalization, and the new guideline and FDA recommend not to use in patients with heart failure or chronic kidney disease because it would lead for hospitalization. For linagliptin, it's more safe than other group in patients with chronic kidney disease and no need for dose adjustment in this group of patients. What's about chronic kidney disease? Chronic kidney disease, diabetic kidney disease is typically developed after diabetes duration of 10 years in type 1 diabetes, and about around maybe at present of diagnosed type 2 diabetes, maybe the patients they have CKD. Why we need to manage this type of patient to decrease the risk of CKD progression and reduce the cardiovascular risk. We have a lot of trial. We have 3 trials for SGLT2 inhibitor for patients with the CKD. All of these trials was double-blind, placebo-controlled, multi-center trial, RCT. All of these trials was decrease the progression to the end-stage renal disease and decrease of cardiovascular death. For the last study was published in the previous year, in 2024, it's follow trial which evaluate the effect of semaglutide in chronic kidney disease to evaluate the efficacy and safety of semaglutide in patients with type 2 diabetes. And this trial, it's included around 3,500 patients, divided into two groups of the patients, semaglutide and placebo, to assess whether the GLP-1 receptor agonist, semaglutide, was effective in preventing of progression kidney disease. The primary composite outcome was the kidney failure or sustained more than 50% decline in GFR or death from renal or cardiovascular cause. To the result of this trial, the incidence of major kidney disease was low in semaglutide group when we compared with the placebo group by around 24%, and also the incidence of kidney-specific component events or decline, it's reduced in semaglutide group when we compared with the placebo group by around 21%. Take-home message for management of patients with type 2 diabetes mellitus: glycemic target and glucose-lowering therapy must be individualized. Newer diabetes agent reduce cardiovascular irrespect, A1C should be considered. Combination therapy with additional 1 or 2 reasonable comprehensive cardiovascular risk reduction must be primary focus of the therapy. This is my last slide. Thank you for listening.
شكرا دكتور محمد يعطيك العافية. Now let's move to the panel discussion, and I will ask all speakers to join us.
Thank you all for your nice and informative presentation. My question is to Dr. Faris regarding the anti-obesity medications. Regarding the semaglutide, as we know, there are two brands for the semaglutide. We have the Ozempic, which is approved for the diabetes, and we have also Wegovy, which is approved for the obesity. So, for example, in our formulary, we have the Ozempic. And at the same time, we use it for the diabetes and also for the weight gain. Do you think that we need to have the both formulation in the formulary, despite the only difference that regarding the Wegovy that it has higher strength, which is the 2.4? Or is it going to be enough to continue with Ozempic and to use it also for weight gain? Thank you.
Thank you, Dr. Faisal, for your question. If I understand your question regarding the weight loss, there is no major benefit regarding the Wegovy when compared with the Ozempic. However, we have other options, as you see before, such as tirzepatide, which achieved higher weight loss than semaglutide because different mechanism of action. It works by dual action, GIP and GLP-1. If you asking about the other benefit, such as diabetes or other cardiovascular, I still have no clear point on the other factor. Regarding the obesity, I think Wegovy is enough.
I would like to ask Dr. Faris if you can contribute as a pharmacy director. When you have the two options, you have Ozempic and we have Wegovy, will you consider adding the Wegovy while you have Ozempic in your formulary? Ozempic and Wegovy, which is both of them are semaglutide.
يفتى ومالك في المدينة مدام دكتور فارس. I agree with Dr. Faisal. This question has been raised to our pharmacy many times for considering both medications. I think one item is enough for the pulmonary. Sometimes you need the oral formulation, but I think there is no scientific difference in terms of effectivenesses, so we can go with one formulation. So I would choose the cheaper one of both.
I agree with you, Dr. Ali. And regarding the oral option, there is ongoing more than a lot of medication, and in the pipeline more than 43% of the oral medication tested in the such patient, obese patient. And there is two medication targeting the GLP-1. It work the same mechanism for liraglutide. It will become in the near future. I'm not sure if it next 2 years it will be available. We have orforglipron and semaglutide oral, 50 milligram.
Dr. Marzouk, do you think we need to bring both injectable and oral?
Definitely we need that, because having variety of options give us a better way to control blood glucose. Like if you want to go to Riyadh, you can go by plane and by car and by train. So whatever suits the patient, go with it. Some patient afraid of injection, so oral semaglutide, which is called Rybelsus, will be a good option. The Wegovy, he mentioned that it's a semaglutide but injectable. The difference between semaglutide, the Ozempic, and Wegovy is the dose only. But regarding the oral semaglutide, which is called Rybelsus that we have, it's great to have many options. It's one of the suitable way, because some, as I mentioned, that they're afraid of injection, so oral could be an option for them. On the other hand, some prefer weekly injection, so we go with that one. Whatever suits the patient, we are happy to do it. And if it's available, of course, it's one of the advantage and one of pioneer to be delivered to the patient.
And Mike, تفضل.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much for very wonderful presentations. I have a question. My name is Fahad Al-Anizi, College of Medicine, University of Hail. I have a question to Dr. Marzouk. In one of his slides, he showed us the A1C was 7%. However, the level of the glucose was not under control. So what's your take-home message from this slide that you would like to share it with us all?
Okay, thank you for your question. Well, as we know that if we do have time and range, it's way better to assess the controlled blood glucose. But I'm not saying or underestimate the A1C. A1C, it's a good marker. We can say that the diagnosis criteria based on A1C. A1C, for those who are not being diagnosed with diabetes, it's a good marker. Those who are taking oral medication, it's a good marker, because the fluctuation is not, it won't be much with those who's taking oral medication. But those with taking basal bolus, the variation will be high. So sometimes you end up with hypoglycemia, another time hyperglycemia. So ups and downs, the A1C will give you the median of the both readings. So I remember one case in the clinic, the patient came with A1C 9. So after 3 months, when we checked the A1C was 6.5. So we said it's good. No, but when we check the CGM, the hypoglycemia rate was more than 30%. So 6%, it doesn't mean that A1C is controlled. So if the patient is on basal bolus insulin, so we would rely on CGM time in range. And even now there is a new term called tight time in range. So we're still waiting to establish it as well.
Thank you so much. Sorry, I have another question to Dr. Mohammed Rashidi. He showed us many studies where they compare the cardiovascular and renal outcomes with different medications, and all these medications were compared to placebo. You keep in mind that those patients are diabetic. We're concerned about their cardiovascular and renal events. Do you think is it legal or it's ethically accepted to compare it with the placebo instead of compare it with best available drug? Because by the end of the day, those individuals are patients and need some care to be taken. Thank you.
Actually, I agree with you. The comparator is active medication for glycemic for diabetes patients. It's better than placebo. But what we have in the evidence now, until now, it's most of the comparator it's placebo, not with the active comparator. I'm totally agree with you. It's better to be active comparator. It's better than placebo.
Thank you, everyone. Actually, I have a question for Dr. Faris. It's about the GLBs, and what I see in the practices on a daily basis, there is a rebound rate. Once the patient stops taking the GLBs, he may gain more than the weight he lost it already. So how we could prevent this rebounding effect of GLBs?
Thank you, Doctor, for your question. As you know, this medication, most of this medication work by stimulate a gut hormone, such as GLB-1, GIP, and glucagon. The gut hormone responsible for decrease satiety and increase nausea and decrease gastric emptying. Once a patient not adhere to this medication or not adhere, as you know, lifestyle is a part of the treatment. Medication alone not enough, and the lifestyle is a part of medication. Once a patient stop the medication and not adhere about life, the physiology of gut hormone, it will come back, and the patient will be high risk to developing a weight regain. So as you say before, the framework for obesity, it consists of agreement and between the patient and the healthcare provider about the goal of weight loss and the strategy how to adhere to the lifestyle modifications, such as the dietary changes, exercise, and the behavioral therapy. And behavioral therapy is the cornerstone of lifestyle modification, because the patient have to adhere and modify to the exercise and the food and any other causes that may stimulate or interfere with this plan. So adherence for lifestyle, medication not enough. It should be combined with the lifestyle, and the patient should be don't forget to follow up every 3 to 6 months to avoid the weight regain.
So much. Yeah.
I want to only give some small kindly advice for our diabetologist. If any patient came from our hand to your hand, if you do mind, please don't stop SGLT2 inhibitor whatsoever.
Excellent.
And don't increase the dose to 25, either the DABA or AMBA or anything. Any heart failure patient, BAF, RAF, improved, any patient came to your hand, make it anything you wanted. But don't increase the dose from 10 in order to this kindly dose, which is all evidence-based mention. All our patient, variety of any heart failure patient, keep the dose in 10. And you feel free for other medication you wanted to adjust his level of blood sugar. Thank you.
So you will recommend to take care about cardiac protection with the other factors?
Yeah. This is our concern at the cardiologist. And always share decision in order to the patient came to me, I decrease the dose from 25 to 10. And then he back to him. He will increase the dose in order to the blood sugar is not well controlled.
Excellent.
So my concern, kindly, leave our medication even if he is not diabetic, even. If he is diabetic, so either heart failure with reduced function, mild reduced function, preserved function, improved ejection fraction, keep our dose as if guideline mentioned. Thank you.
I hope your message reached to all pharmacists now. شكرا لكم. Now we will end our session. شكرا لكم.
المتحدثين على هذه المعلومات القيمة، وأود أن أدعو الدكتور علي البناوي إلى المسرح لتكريمه. الدكتورة جوزة السبهان. على أن نعود لاستماع على أعمالنا السيدات والسادة، أرحب بكم مجدداً لنختتم جلساتنا العلمية بجلسة بعنوان Biologics and Chronic Disease Management Long-Term Outcomes and Challenges. سنناقش في هذه الجلسة الدور المتزايد للعلاجات البيولوجية في إدارة الأمراض المزمنة، مع التركيز على الفوائد والآثار طويلة الأجل، بالإضافة إلى التحديات التي تواجه تطبيق هذه العلاجات على نطاق واسع. تدير هذه الجلسة مدير إدارة سياسات وتنظيمات الأدوية بوزارة الصحة، وهي صيدلانية إكلينيكية مختصة في علم الأورام، وهي واحدة من أبرز الخبراء في مجال
disease area, rheumatology, IBD. Let's get started with the first speaker. I am honored to introduce Dr. Amaram Al-Anizi, a consultant in drug information Today I will talk about the new era in Crohn's and ulcerative colitis management, mainly focusing on biologics. I have no real or potential conflict of interest related to this topic. So my objectives for today, I will cover a short background about ulcerative colitis with the differences between them. We will talk about the epidemiology of IBD in Saudi Arabia, and we will discuss international and the MOH guideline. And at the end of this topic, we will discuss the specific characteristics of each biologic and the uses in special population. So, inflammatory bowel disease, it's an autoimmune disease characterized by a chronic intestinal inflammation, which is a result from a host microbial interaction and in genetically susceptible individual. We have two types or two forms of IBD. Ulcerative colitis, which is a mucosal inflammatory condition and mainly confined to the colon and rectum. The other type is Crohn's disease, which is a transmural inflammation of the GI tract that can affect any part of the body from the mouth to the anus. So, as epidemiology, as you know, in the past 20 years, the incidence of ulcerative colitis was reported and steady. However, Crohn's was increased. These data here, as you can see, the ulcerative colitis incidence in Saudi Arabia is 1.2 to 20 cases, while Crohn's disease is 6 to 15.5 cases per 100 persons per year. And the main reported age of onset of inflammatory bowel disease is usually at young age, from 25 years. So here, the characteristics or the differences between ulcerative colitis and Crohn's disease. As I mentioned, for ulcerative colitis, it's usually super inflammation affected mainly the mucosal area and limited to the rectum and colon, which one of the diagnostic criteria. Also crypt abscesses considered as a hallmark, and patient usually have a continuous disease, start from the rectum, then can expand until we have pancolitis. While for Crohn's disease, it's transmural inflammation. As I mentioned, it's usually affect any part of the body from the mouth to the anus. And it's considered as a discontinued disease, or we called it skip lesion. And very common to have fistula formation with the Crohn's disease, opposite to ulcerative colitis, which is not there. So what are the goals of our management for those patients? First, to resolve the acute inflammatory process, which is reduce the progression of the disease, and also prevent the further complication that happen with IBD. Elevate any extraintestinal manifestations such as rheumatoid or optic effects. Also improve patient quality of life and reduce further complication. So today I will discuss mainly the Saudi Arabia consensus guideline, which was published in 2022. This consensus include a 78 statement focused on diagnosis and medical treatment of IBD, and this is the guideline we are followed here or in our hospital. This guideline for management of IBD were developed by the Saudi Ministry of Health in collaboration with Saudi Gastroenterology Association and the Saudi Society of Clinical Pharmacology. They reviewed different international guidelines such as European Crohn's and Ulcerative Colitis Organization, AGA, ACG, and also the British Society. So I tried to summarize the recommendation mainly in form of severity. So I will start with ulcerative colitis. For mild to moderate management, usually we don't use biologics. However, we use topical or oral mesalamine as induction. And if patient cannot tolerate mesalamine due to allergy or treatment failure, we can go with budesonide, which is the recommended medication. For maintenance of remission, we will continue either with mesalamine, topical or oral, and sometimes thioprine also can be used in those patients. While for moderate to severe patients, usually we will start with a biologic. Either the patient already came or the first contact was a severe patient, or patient who have mild to moderate but failed the conventional therapy. Now we will go for biologics. If the patient considered naive, which is first time of exposure, usually we will give different biologics such as infliximab, golimumab. The one with the asterisk is considered as central medication and is a formulary item. However, the one with the hashtag is considered a non-formulary item. Also, we have ustekinumab, rasincuzumab, and guselkumab, which is considered as a strong recommendation to be used as a first line with thioprine. Or we can also use adalimumab, filgotinib, considered as a conditional recommendation. If patient failed the previous line, or considered as experienced either due to treatment failure or intolerance, we can go with the JAK inhibitors such as tufastatinib or obatacitinib. In addition to that, also we can combine glucocorticoids or systemic steroids in combination with biologics. As a maintenance, patient can continue on the same treatment of biologics plus thioprine or biologics alone. However, all the recommendation, they mention patient, they have superior effect if they use biologic plus thioprine. Here the AGA guideline, which was published in 2024, also have similar recommendation as the one I mentioned of the MOH guideline. However, they mentioned or they categorize the medication according to the efficacy. We have higher efficacy medication such as infliximab, which is considered as a first line. Also intermediate efficacy medication, such as ustekinumab, and lower efficacy medication, which is as adalimumab. So those patients may be at high risk of treatment failure. If patient is experienced or either due to, as I mentioned, treatment failure or intolerance, also they mentioned higher efficacy medications such as tafastinib, intermediate efficacy, and lower efficacy also such as adalimumab. This systematic review and meta-analysis was published in February 2025. They reviewed 36 studies, fulfilled their inclusion criteria, which is include more than 14,000 patients with ulcerative colitis. Obadasitinib, it shows a superiority against all biologics in terms of clinical remission and also in terms of endoscopic improvement. So, as a summary for ulcerative colitis, the choice therapeutic agent or biological agent, it's based on patient characteristics. Is he naive or experienced? Also based on the availability of the medication. As I mentioned, not all of the biologics are part of our formulary, and at the end, administration. So some patients, they preferred IV infusion, and some of the patients, they preferred either oral or self-administered medications. The guidelines, they recommend use of biologics for ulcerative colitis patient rather than having patient on high doses of mesalamine, either oral or topical. In addition to that, they prefer vedolizumab, which is more gut selective for a specific group of patients, such as old age, more than 65. Patients have history of malignancy, and patients who have history of serious infection. Why is that? Since it's more gut selective, so less systematic exposure for those patients. Also, it's really important to know that using tafastinib for patients who have history of thromboembolic disease or cardiovascular disease, or they have age more than 50, they have increased risk of thromboembolic events, so we need to be carefully for those patients. Now we'll move to Crohn's disease for patients with mild to moderate. So as a first line for induction, we will use oral budesonide, which is mainly confined to the terminal ileum and to the right colon. And in case if it's not available or patient cannot tolerate, we can go with prednisone. As a maintenance, patient can continue on budesonide and immunomodulators. And this is based on a meta-analysis conducted in 2019. For moderate to severe, also based on a pool analysis of several studies, they found that as induction, we could use systematic corticosteroid. They prefer methylprednisolone. And also biologic. If patient naive, they prefer to use anti-TNF, which is approved for Crohn's disease, adalimumab, infliximab, and we have also certolizumab. However, infliximab and adalimumab were reported to be more superior than certolizumab. With thioprine, such as azathioprine. For experienced patient, we can use ustekinumab with azathioprine or alone, plus vedolizumab, as I mentioned, for a specific group. And if patient having preanal fistula, they preferred, or the evidence showed that the closure is better with infliximab plus the antibiotics. If patient cannot tolerate infliximab or treatment failure, we can go with adalimumab. As a maintenance, we can go with the same biologics that we started with, thioprines. So as a summary for Crohn's disease, similar, we need to choose the appropriate medications or biologics based on patient characteristics, preference, and type of administration and cost. Also, they recommend early initiation of biologic therapy, especially for high-risk feature patient. They recommend against using mesalamine for induction and maintenance remission for Crohn's disease. It's not recommended. It's only for ulcerative colitis. Infliximab combined with azathioprine and adalimumab monotherapy were reported to be more superior than certolizumab. However, certolizumab have more added benefit to be used during pregnancy. Ustekinumab was reported to be more effective than vedolizumab on a long-term basis. So here I summarize some of the basic characteristics for each group. It's really important to know the doses, the frequency of administration. So as a healthcare provider or as a prescriber, we need to discuss those with the patient so that they can understand the consequences of this disease and the duration, and they have to be on schedule. Also, as a healthcare provider, it's really important to know the risk minimization measures, which is available for most of the medication. Here, it's available for infliximab, ustekinumab, and tofacitinib. It's easy to access. You can access through your MOH formulary and the risk minimization measure, or you can go as simple as to the Saudi FDA websites and just write down your medication name, and all the material will be available for your reference. Here, I just put some important points to be discussed with a special population. As we all know, for patients with congestive heart failure, it's not recommended to be used anti-TNF. It will worsen the cardiovascular effects for the patient, so they recommend to use ustekinumab or vedolizumab. So for patients who are having hepatitis B or patient with TB, active TB, they have to be started on their medication. Then, like after 1 month, they will initiate the biologics. For pregnancy, actually, there are some recommendations. Also, the Saudi consensus, they published a separated guideline for medication used in pregnancy. However, I summarized a few points. Previously, the anti-TNF was not preferred to be used in pregnancy. However, now it should be used during pregnancy, or if the patient was on anti-TNFs, she can continue. However, it should stop before the 3rd trimester. Why is that? Because to limit the fetal exposure for biologics. As I mentioned, certolizumab is also preferred to be used in Crohn's disease, and really important to avoid live vaccines for the first 6 months of infant of a mother who have received biologics during her pregnancy. And also, upadacitinib was not recommended, or it was not reported to be safe during pregnancy. For breastfeeding, here also I put some points. However, usually for each medication during breastfeeding, it's really preferred to go and check some important resources such as LactMed or the prescribing information to make sure there is no content of the medication on the breast milk. Here I just put the list of FDA-approved biosimilar products. We have for adalimumab 10 approved biosimilars. We have for ustekinumab 7 approved biosimilars, and some of them they are registered in our SFDA. And for infliximab, we have 4 registered biosimilars. Thank you all for your listening.
Thank you, Dr. Maram. It was a really informative session. Let's move to the next speaker. I'm pleased to introduce Dr. Khalid Al-Anizi. Dr. Khalid Al-Anizi, distinguished pharmacist and healthcare leader with over 19 years of experience in drug information, health economics, and pharmacovigilance. She is executive director of transformation, planning, and business development at Tabuk Health Cluster. Dr. Khalida also serves as the Vice President of the Saudi Pharmacovigilance Society and represents Saudi Arabia in the ISOP Middle East chapter. Please join me in welcoming Dr. Khalida.
السلام عليكم ورحمة الله وبركاته. أول شيء حابة أشكر الجميع، حابة أشكر صيادلة حائل بصراحة على هذا الترحيب. بصراحة يعني من زمان أنا ما كنت جزء من مدة تقريبا سنتين جزء من أي إيفنت خاص للفارماسي. الدكتور علي رجعني للصيدلة، فأنا حابة أشكركم جميعا. رح نتكلم اليوم عن الادفانس بيولوجيك ثيرابي في السورايسيس، الجايد لاينز، سعودي جايد لاينز اند الريال وورد امبلمنتيشن. بداية we don't have any potential conflict of interest. شيء ثاني راح نبدا بأول شيء باك جراوند eligibility criteria for biologics, the treatment goal, the biologic agent available in the Saudi market, dose and the efficacy or efficiency of the biologics medication, adverse drug reaction or adverse event associated with the use of biologics, long-term efficacy of the biologic, also registry, psoriasis registry. As you know, psoriasis is a common chronic skin disease, autoimmune disease. Is effective around 125 million globally. The incidence or the prevalence here in Saudi Arabia around 2%. It's high in the eastern region. Comparing with the other region. In Riyadh, 2.3, around 2.3 or 2.4, the prevalence of the disease. But as you know, في الدول الإسكندنافية في القوقاز عندنا البريفلنس للسورايسيس أو المناطق الباردة عالية جدا، توصل ممكن ل 11%. طبعا كلنا عارفين أي patient psoriasis، إحنا ما قاعدين نتكلم عن disease ممكن إنه الألم يكون داخلي انك تحس وتقدر تتعالج او تتاقلم معه. احنا في شيء ظاهر على السكن، خاصه اذا كانت في الفيس، في اليدين، في الهاند، في النيلز، فهذه كلها افكتد للكواليتي اوف ذا لايف بالنسبه للبيشنت. وهنا حتى لما اجينا عرفنا المودريت تو ذا سيفير، كان من ضمن الكرايتيريا اللي حطينا له انه يعني اكسبت هذه الكرايتيريا should be used or starting البيولوجيك as soon as possible. اوكي، خاصة ان احنا عاوزين ان نوصل مثلا باسي 90 with the short term from the 12 to the 16 week. طبعا mainly الايدج اللي بيصاب فيها البيشنت السورايسيس او هذا الاوتوميون ديزيز كانت ما بين ال 20 to the 30 وما بين ال 50 الين ال 70. كثير حالات، يمكن اول حاله انا مسكتها كانت بيولوجيك كانت لبيشنت سورايسيس، كانت للترمفايا، فكان الاتشيفمنت خلال 12 اسبوع كانت هذه الفيميل على وجه زواج. فكان بالنسبه لها انها كانت في مرحله اكتئاب، وانها حتى انها قررت انها تنتحر تنهي حياتها. فكانت هذه الحاله عند الدكتور خالد العطاس استشاري ديرماتولوجي في جيزان. فهذا اللي خلاني اني اهتم بهذا الديزيز اريا بالضبط، يعني كيف كان فعلا الامبروفمنت والاتشيفمنت للدواء خلال فتره بسيطه 12 ويكس. البيشنت بدا ستارت تو ذا امبروفمنت الباسي، بدا من 75 تو ذا 90. البيشنت امبروف توتالي 100% بيفور التايم حق الزواج تبعها، كانت توتالي امبروف. ففعلا تحس نفسك انك هنا انجزت. طبعا عندنا 80% من الكيسز السورايسيس محتاجين توبيكال كورتيكوستيرويد، فيتامين دي انالوج، فوتوثيرابي. بالاضافه بعضهم يحتاج فعلا 1 to the 5. احنا محتاجين بايولوجيكس تو ستارتنج، خاصه في حالات البيشنت فيلد على السيستميك تريتمنت، السايكلوسبورين، الميثروتركسات، الابراليسيمنت مع انه قليل استخدامه. فاحنا الحين حاليا في مرحلة إنه أنا ما راح أعرض البيشنت لفترة طويلة من التريتمنت without any improvement. فالوزارة هنا قررت فعلاً إن نبدأ خطوة جديدة، إن نعمل جايد لاينز. طبعاً كنا من أوائل الجايد لاينز على مستوى العالم ككل. على مستوى العالم ما في إلا 7 جايد لاينز كانت تخص التريتمنت المودريت تو ذا سيفير سورايسيس. طبعا احنا كنا تقريبا اخذنا الميثودولوجي اللي استخدموها في النايس وبدينا نشتغل عليها. طبعا من جايد لاين لجايد لاينز استخدموا تولز معينه، وهذه التولز اللي استخدموا فيها الاسيست الامبروفمنت حقه البيشنت. طبعا احنا نبغى نشوف كيف الامبروفمنت حقه البيشنت، فاما يعني نستخدم الباسي تولز او البي جي اي اللي هي الفيزيشن جلوبال اسسمنت، او البادي سيرفيس اريا، الافكتد بادي سيرفيس اريا هي في اي مكان. فكانت اختلاف على حسب كل جايد لاينز وايش هم اعتمدوا. احنا في وزاره الصحه او جلوبالي على الليفل الناشونال اعتمدنا على الديرماتولوجي كواليتي لايف، اوكي، واعتمدنا كمان على داي كومبانيز. احنا عاوزين ان نوصل مثلا اتشيفمنت 90% في الباسي during first 16 ويكس الاولى في when starting day treatment. فكان هذا الهدف او الجول اللي احنا اشتغلنا عليه. طبعا احنا وي نيد كثير biologics دخلت الماركت في different البرايس تبعتها، في variation في البرايس، فين مين الافضل منها. كل طبيب راح يجي يقول لك انا جربت هذا انا جربت هذا. فكان هنا ان حاجه لابد لها ان نبدا نعمل جايد لاين. اجتمعوا 8 ديرماتولوجيست على مستوى السعوديه، كانوا هذول اكسبرتيز كديرما فيزيشن، ومع بالاضافه كان عدد الصيادله اللي شاركوا في الجايد لاينز 5. وبدينا نحط الاساسيات حقت التريتمنت. اول شيء عرفنا الإليجابيلتي كرايتيريا، انا متى ابدا استخدم بيولوجيك تريتمنت. طبعا في عندي شخص شارك معنا الدكتور عامر خردلي معنا في الجايد لاينز. فبدايه عرفنا ايش هي الكرايتيريا اللي احنا محتاجين عشان انا ابدا فيها انه هذا البيشنت is diagnosis at moderate to the severe. First things we're looking على البادي سيرفيس اريا should be انها تكون more than 10%. الباسي او السورايسيس اريا and the severity index more than 10% or equal. الديرماتولوجيكال لايف equality index كانت more than 10%. الاذر الكرايتيريا we're looking على هي فين البريسنس. اذا كانت في سبيشال اريا كنا فعلا احنا لازم يعني نبدا فيها، خاصه في النيلز، خاصه في السكالب، خاصه في الجينيتال اريا. هذه كلها اخذنا لها انه لازم شود بي انه ستارتنج البيولوجيك ايفن انها يعني لانها ديفرنت بصراحه difficult to treat هذه الاريا. راح نعاملها معامله المودريت تو ذا سيفير. بالاضافه البيشنت احنا عندنا 80% from the patient develop psoriasis راح يدخلوا على طول مع الوقت ككومبليكيشن من بعد السكين، راح يبدا يتاثر عندهم الجوينتس، فراح ندخل في سورتيك ارثرايتس. فاحنا كان لازم ان نوقف هذه البروجريسز حقه المرض. فراح نبدا للبيشنت مجرد اي وحده من هذه الاعراض بدا فيها راح نبدا يعني البيولوجيكس. بدايه كان الجول تبعنا الفيزيشن جلوبال اسسمنت، وهذا النايس اخذت فيها كاوتكم انه السكور تبعها يكون من 0 to 1، انه الاتشيفمنت في الديرماتولوجيكال لايف كواليتي اندكس تكون less than or equal 5. في الجايد لاين كانت equal less than 5، بس الحين حاليا في الاوتكمز صرنا ناخذ انه equal or يعني less than. السورايسيس سيفيريتي اندكس كانت less than 3. برضو الريسبونس لل 90 او الباسي 90 لازم ان نوصل اتشيف تو ذا 90%. كل الحين الانترناشونال وي لوكينج الحين المرحله هذه راح تشوفوا انه راح نبدا جايد لاينز جديده، راح وي لوكينج على الباسي 100 انه خلال 12 تو ذا 16 ويك انه البيشنت امبروفمنت توتالي كامل، ما في اي يعني انفكتد اريا او اي مشكله اي اريا فيها افكت يعني من السورايسيس. البيشنت before starting to the biologics should be assessed ميني بارامترز. الليبيد بروفايل كلنا نعرف ليه، السي بي سي، التي بي علشان التي ان اف انهبيتور ممكن تعمل اكتيفيشن للتي بي، الشيست اكس راي عشان التي بي برضه، البريجنانسي تيست. وهذه كبيس لاين. ذن كل 6 مانث نعمل مره ثانيه ري اسس لبعض البارامترز، وهذه اللي تهمنا اللي هي الليفر انزيم، الرينال فانكشن، بلس. اما الانولي راح نضيف عليها التي بي بلس الليبيد بروفايل. في عندنا طبعا السورايسيس دائما يكون associated مع complication، يعني ما راح تلاقي patient عنده psoriasis without other comorbidity ثانية cardiovascular morbidity أو غيرها. فإحنا we looking دائما إنه الباراميترز هذه نعمل لها screening أول بأول، الليبيد بروفايل وغيرها. والأنتي بوديز طبعا بداية إحنا راح نبدأ أول شيء بسيستميك تريتمنت، سواء كانت طبعا أنا ماني شايفة الشاشة. بداية راح نبدأ مع الميثروتروكسيت والسايكلوسبورين. بيشنت خلال 16 من from 12 to the 16 week صار improvement خلاص completely، نكمل معاها continue treatment. patient not achieve أو patient ظهرت عنده contra indication أو adverse event لهذه السيستميك treatment، لا هنا لازم إن نبدأ switching البيولوجيك تريتمنت، وهذه واحده من الكريتيريا اللي شود بي نبدا فيها البيولوجيك. متى ما ابدا ببيولوجيك؟ لما يكون يظهر عندي اي ادفيرس ايفنت، اي كونترا انديكيشن شود بي ستارتد. بيشنت والسورايسيس ودونها ما دخلنا بسوراتيك ارثرايتس شود بي ستارتنج وذ الاي ال 23. كان عندنا تو اوبشن من الاي ال 23، الريزا او السكايريزي والترينفايا. بيشنت بعد 16 اسبوع ما اعطى او من 12 to the 16 ويك ما صار فيه improvement should be switching to the IL-17. وكثير من البيشنت بهذه المرحله تلاقيهم صار عندهم joints complication ومشاكل في الجوينتس، فتلاقينا حولنا على طول على IL-17. بعد ما البيشنت يعني وصلنا لمرحله دخلنا في IL-17 وصار فعلا البيشنت not response should be returned to the TNF inhibitor. طبعا احنا احنا TNF inhibitor available في الوزاره، لكن هو خيار كثيرد لاين ما هو كفيرست لاين. ليش احنا نتعب المريض؟ احنا وي لوكينج على الكواليتي الحين اوف ذا لايف، نوت لوكينج على ان انا اتعب المريض وابغى اعمل ديسكاونت ولا ابغى اقلل الكوست. لا بالعكس، انت لما تتعب المريض اكثر لما تعطيه اكثر ميديكيشن. عندنا كثير ادويه الحين ما بالماركت افيلابل، من الاي ال-17، من الاي ال-23، من الاي ال-12-23 الاستيلارا، بالاضافه للتي ان اف انهبيتورز. هذه كلها افيلابل للسورايزز في المملكه. طبعا وقت ما كنا موجودين 1 ميديكيشنز بدينا بالجايد لاينز، كانت واحده من الميديكيشن الاي ال-23 نوت افيلابل ان ذا ماركت، لكن كانت ماخذه الابروفال من الاف دي اي الامريكيه، لكذا ما كانت انكلودد او ما صار لها منشن في الوزاره. راح نشوف هنا على المدى القريب اول شيء الاندكشن افيكاسي. راح تشوفوا في فاريشن. ليش احنا ما بدينا اول شيء بالتي ان اف انهبيتور؟ كفارماسيست لازم انك تعرف ليش احنا ما بدينا. اول شيء لو تشوف الهيوميرا او التي ان اف انهبيتورز، الاتشيفمنت في الاندكشن بالفيرست ويكس مثلا اللي عندك البدايه 16 اسبوع راح تشوفوها قليله جدا، 45%. هي اعلى شيء عندنا الانفليكسيماب. اوكي، لكن البيشنت از نوت بريفير الانفليكسيماب لانه انجكتبل والرياكشنز والامور هذه، فما يحب ياخذها. عندنا اجى الماجيك بالنسبه للسورايسيس بيشنت اللي هم الاي ال-23، فكانت الريزا وكانت الترنفايا حاجه ماجيك. فكانت على مرحله الاندكشن، لو انكم تشوفوها في مرحله الاندكشن الفيرست 16 ويكس توصل ل 73% كاتشيفمنت بالباسي. اوكي 90، يعني عندك 70% من البيشنت هذول كلهم امبروفمنت وصلوا للباسي، يعني كلير عندهم السكين الان. 90% من الجسم عندهم كلها فيه صار امبروفمنت. راح تلاقوا كمان عندكم الاي ال-17 بس اقل برضو من التي ان اف اقل من الاي ال-23. استيلارا احنا بنعطيه لبعض بعض الكيسز اللي عندهم يكون مثلا associated with comorbidity مثل ulcerative colitis مثل هذا، فاحنا نعطيها فيعني نكون عالجنا اكثر من disease area بنفس الوقت. التالز والكوزانتكس راح تشوفوا انه اقل الافيكاسي تبعته كباسي انه يوصل ل 65% في ال 16 ويكس الاولى. اثنيناتهم متشابهه يعني متقاربين بالافكسي. احنا كنا في الوزاره اخترنا التالز بناء على الافكسي، الاندكشن افكسي واللونج تيرم افكسي اللي هي 52 اسبوع، نوصل ل 70% مع التالز من البيشنت كلهم توتالي امبروفمنت في الباسي. ما راح اتكلم عن الادفيرس ايفنت لانها من الليتلتشر اخذناها من البيفيتال ليتلتشر. طبعا انا كصيدلانيه ام لوكينج على البوست او الادفيرس ايفنت اللي بعد ما الميديكيشن يصير له ماركتينج. في عندنا اللونج تيرم افيكسي، شفنا جميع الدراسات الاكستند او اللي كانت مدتها اكثر من 5 سنوات، شفنا السرفايفل ريت. طبعا يعني ايش الدواء هذا راح يستمر بالافكسي تبعته ولا ما راح يستمر؟ في كثير عندنا من التريتمنت تخسر، يعني خاصه البيولوجيك يخسر او يوصل للافكسي بعد السنه الاولى، وهذا احنا ما نبغاه. احنا نبغى على المدى الطويل، لانه بيشنت السورايسيس كرونيك يعني اوكي ممكن مجرد ما يوقف الدواء ممكن يرجع الوضع الاول. فاحنا محتاجين السرفايفل ريت انه يكون مرتفع، كل ما كان مرتفع كل ما احنا وي ريتش الجول اوف ذا تريتمنت. اوكي فكانت الاي ال 23 بصراحه الريزا والترنفايا هم الهاي سرفايفل ريت لهم، نوصل اراوند 60 تو ذا 82 كنتيجه بالنسبه للباسي 90 اوفر 5 years. اوكي بالنسبه للتالز والكوزانتكس 60% خلال ال5 سنوات. وفي بيبر احنا نشرناها مع الدكتور ابراهيم الحمود حاليا عن السرفايفل ريت، جيتوا علي بدقيقتين حيهتوني. طيب اوكي فكانت على السرفايفل ريت لمده 3 سنوات، بصراحه كانت يعني جدا رائعه. كانت السبيسيفيك بيشنت قسناها احنا في السورتيك ارثرايتس بيشنت نوت وذ سورايسيس بيشنت، وكانت الافكسي عاليه بصراحه، والسرفايفل ريت للميديكيشن كانت جدا رائعه. فبالتالي هذا يطمنك لما انت تدخل واحد من هذه الادويه، انت عارف for 5 years هذا الميديكيشن انت we not needed to that change or discontinue في حاله مثلا انه dislisted او انه مثلا صارت عليه adverse event معينه، فهنا انت مضطر هنا تعمل له discontinue او انك switching ل other treatment. حاليا احنا عندنا ليش بدينا نشتغل في الوزاره تقريبا على الريجستري، وايش الاسباب حقت الريجستري؟ احنا محتاجين ريال داتا ايفيدنس، محتاجين نعرف البريفلنس بالضبط للديزيز. يعني احنا ما كنا عارفين انه انا عندي 2.4% في الرياض فقط البريفلنس حقت الديزيز، كم راح يكلفني البيردن كوست لهذا الديزيز. الحين كل شيء محتاج انك انت تحسب في البيردن كوست، الامباكت حق الميديكيشن الفلاني لو دخلته ايش راح يكون امباكت إلك. فهذا كان ايش اسباب ان نشوف الريجستري. شيء ثاني علشان السيفتي، كثير من الميديكيشن يصير لها ديسكونتينيو واحنا ما احنا عارفين ليش صار لها ديسكونتينيو، يكون مثلا سيفتي ايشو. فالريجستري هو ريال داتا ايفيدنس. لاست سلايد. اوكي بدايه في الريجستري في الانيشال فيزيت راح نطلب البيس لاين حق الاكزامينيشن بيس لاين. اوكي راح نطلب التست اللي احنا تكلمتكم عنها، ايش الكرنت ميديكيشن عشان مثلا اذا كان في دراج انتر اكشن، الدوز، السايد افكت اذا البيشنت كان عنده اي سايد افكت، وضع الديزيز. يعني الدكتور هنا يشخص لازم عنده بالثلاثه اوت كمز يشخصها، واهم شيء الباسي. اوكي التشينج بالباسي 90 هذه ضروري من افضل الاشياء اللي احنا نعتمد عليها. افتر 12 ويك أو بعد 16 أسبوع وال24 أسبوع راح نرجع مرة ثانية نعمل أسس. الدكتور راح يرجع للباسي وللكواليتي اوف ذا لايف، الدرماتولوجي كواليتي اوف ذا لايف، ويتأكد هل البيشنت أوكي أموره تمام، أتشيف التارجت ولا لا، أتشيف التريتمنت جول ولا لا. في حال لا هنا يوقف الدواء او انجوينج يكمل على حسب الاتشيفمنت في كريزلت. بعدها بعد 6 مانث شود بي الدكتور يبدا يعمل ري اسيس مره ثانيه، وبنفس الوقت يطلب برضو تيست اكثر ويتاكد من الجنرال سيتويشن للبيشنت، هل بدا عنده ادفيرس ايفنت، هل كل الامور كامله، الديزيز ستاتس مثلا اوكي في امبروفمنت بس بارشال امبروفمنت، وهنا هذا مش مقبول. خاصه احنا عقودنا مع الشركات كانت كاوت كم. اوكي البيشنت نوت اتشيف during ال6 months الاولى، انت مضطر هنا انك تدفع لي قيمه هذا البيشنت. اوكي تتغرم بهذا الموضوع، انت تشيل هذا البيشنت. راح نشوف هذه المرحلة، أوكي، هي بعدها كل 3 شهور راح نعمل فولو أب. بعدها في الأنوال نشوف البيشنت الستيتس حقت الديزيز كيف، الامبروفمنت تبعته، احنا وين وصلنا، البيشنت راح يكمل ولا ما راح يكمل. وبعدها نعطي ريبورت كامل. اصلا الوكاله المساعده تطلع ريبورت كامل بالنمبر اوف ذا بيشنت اللي استجابوا للعلاج والنمبر اوف ذا بيشنت اللي فيلد، وكذا نكون حتى اخذنا حقنا من الشركات. وصل. فيعطيكم العافيه. اتوقع اني اوجزت وكنت سريعه. خلاص كذا، يعطيكم العافيه.
Allah يعطيك العافية دكتورة خالدة. Amazing as usual. Let's move to the third speaker. I'm pleased to introduce Dr. Majid Al-Anizi, consultant in internal medicine and rheumatology at King Khalid Hospital in Hail, where he also leads the rheumatology department. Dedicated researcher and former director of the internal medicine residency program. Let's warmly welcome Dr. Majid.
السلام عليكم. I would like to take this opportunity to express my heartfelt gratitude for the all committee conference and all organized who invite me to this meeting to share the acknowledgement with the esteemed health professional in Kingdom. First of all, I will talk about the وصلنا الأخير. Balancing efficacy and safety of medication in rheumatoid arthritis. Without no further introductions, I will talk about the understanding how common rheumatoid arthritis and its key characteristics, learn about treatment goals and key strategy, explore different types of medication, identify potential medication effect, side effect, and learn how to manage and reduce the side effect. First of all, rheumatoid arthritis is autoimmune disease in nature. The immune system mistakenly attacks the healthy joint tissues. This triggers inflammation and pain. So the global impact of rheumatoid arthritis is 0.5 to 1% of adult worldwide. Women are affected 2 to 3 times. 2 to 3 times more than men. So the main symptom is joint pain, joint swelling, and the joint damage. Without treatment, rheumatoid arthritis causes irreversible joint destruction that leads to the disabilities and decreased quality of life. So our treatment goal and the strategy, we will start from the bottom here. So early intervention within first 3 to 6 months of symptoms onset. Then the control inflammation, reduce pain and swelling to prevent the joint damage and preserve the function and mobility of the joint. So our aim in the rheumatoid arthritis to complete our absence of disease activity. So overall, the goal I said before, decrease the disease activity and inflammation, improve and maintenance the function, prevent and manage the pain. So usually our aim to take the low disease activity and upward aim is remission. And we use a valid disease activity measurement like the clinical disease activity score or disease activity index 28, disease activity score 28 with CRB. I will try just to remind you about the history of rheumatoid treatment. And in the last century, in the beginning, The first line treatment was aspirin, then the gold, steroid, hydroxychloroquine. Since 1980, methotrexate is the driving and staying the cornerstone treatment for rheumatoid arthritis. In the late of the last century, we reached to the biological treatment, and we start with the TNF inhibitors and interleukin-6 and other biological treatment, and we reach in the last 4 to 5 years to the synthetic DMARD. We have now more than 4 or 5 of the synthetics DMARD, synthetics biological DMARD. So as per guideline, according to the last ACR 2021 and ULR 2022, the guideline, the first line of treatment is the methotrexate. So we started with methotrexate, then we'll assess patient after 3 to 6 months. If the patient have poor prognosis characteristics, we will jumping to the biological treatment. If there is no poor prognosis, we can add another conventional DMARD. Then after that, we'll assess and change between the biological depend on the patient condition. So therapy option for rheumatoid arthritis, medication for categorized into the 3 main class based on their mechanism of action and therapeutic targets. So the conventional synthetic DMARD, we know the methotrexate, leflunomide, sulfasalazine, and hydroxychloroquine. Also the biological, the TNF inhibitor, and other is anti-TNF monoclonal antibodies, infliximab, adalimumab, golimumab, certolizumab, and other things, the B-cell depleters like the rituximab and interleukin-6 inhibitor, tocilizumab, and T-cell co-stimulators like abatacept. And recently we have also targeted synthetic DMARD like the kinase inhibitors, baricitinib, tofacitinib, and ubadicitinib, and filogetinib, and beficitinib. So we will start with the conventional synthetic DMARD. First thing, the methotrexate is 60 to 80 effect rate, often combined with other medication for enhanced effect. So enhanced effect of methotrexate itself and enhanced effect of the other medication and biological treatment. Sulfasalazine, moderate efficacy, used alone or in combined. Usually not used alone, but can be used alone, or the majority of patients who use it as combined therapy. Hydroxychloroquine, also mild option, better safety profile, but lower efficacy for severe rheumatoid arthritis. Leflunomide, alternative to the methotrexate, similar efficacy but different side effect. So if we say the second one in efficacy after the methotrexate will be leflunomide, better than sulfasalazine or plaquenil, but the safety of the sulfasalazine and hydroxychloroquine increase their use as a conventional DMARD. So also the methotrexate, most commonly prescribed DMARD, it's highly effective but cause stomatitis, GI upset, liver toxicity, and bone marrow suppression. And some lung issues, sulfasalazine and plaquenil. Plaquenil is a mild option, less potent but useful for management of the RA with relative safe side effect profile. As we said, leflunomide before, but there is liver toxicity documented with leflunomide. Just I want to remind you that methotrexate and leflunomide are contraindication in pregnancy. So usually with sulfasalazine, when we have side effect, we increase over first 4 weeks. We started the medication by reduce back to the previous tolerated dose and increase up to slower and maintenance dose of 1 gram twice a day. For methotrexate, when we have nausea, diarrhea, and mouth ulcer, we can change the time to take in evening and increase the dose of folic acid, and started with low dose of methotrexate. Leflunomide also, we have diarrhea. If on 20 milligram daily, reduce the dose to the 10 milligrams or reduce the every other days. Usually we have the dose of 10 or 20 milligram. We can reduce the dose if we have side effect. So we are now moving to the biological treatment. TNF inhibitor, the first generation biological example, we say that adalimumab, etanercept, interleukin-6, B-cell depilators, and T-cell modulators. So TNF inhibitor is highly effective in controlling the inflammation and slowing the disease progression. However, they can increase the risk of infection and potentially lead to the malignancy. Interleukin-6 target inflammation. Cytokines offered good efficacy, but there is concern about the liver enzyme toxicities and the elevation and increased risk of infection. Example, tocilizumab. So other medication, B-cell depleter therapy, effective in certain rheumatoid patients, but carry risk of infection, infusion reaction, and rarely but seriously condition like progressive multifocal leukoencephalopathy. Example is the rituximab. So B-cell depleter, we have only rituximab for used for rheumatoid arthritis. So adverse effect of biological therapy in rheumatoid arthritis, we have serious adverse effect, MACE and congestive heart failures, lymphoma, non-melanomas, skin cancer, demyelinations, also the hematological effect, LFT abnormality, and infection like reactivation of TB, histoplasmosis, listeriosis, candidiasis, aspergilloma, pneumocystic pneumonia. Also, we have infusion reaction like pruritus, rash, dyspnea, hypertension, chest discomfort, and nausea. So understanding the side effect profile, biological therapy, while effective for RA management, are associated with several significant adverse effects that require careful monitoring. But just note that we have definitive risk factor, definitive risk and doubtful risk. I will elaborate on this point. Because definitive risk, we have infusion and injection site reaction, reactivation of the tuberculosis, minors, infection like upper respiratory tract infection, positivity of the serology, exacerbation of psoriasis, LFT abnormality. The other side, we have doubtful risk factor like serious infection, demyelinated disease, myocardial infarction and heart failures, worsening and reactivation of hepatitis C and B, lymphoma and hematological malignancy, and non-melanoma. In the last years, we moved to the targeted synthetics DMARD, like the JAK inhibitors. We have the tofacitinib, baricitinib, and upadacitinib. All of this are approved for the rheumatoid arthritis. The dose is twice daily for tofacitinib, once daily for baricitinib or upadacitinib. They share the same side effect or adverse effect like the herpes zoster reactivation, blood clot and lipid change, and venous thrombosis. So we have the risk for malignancy and venous thrombosis in all target synthetics DMARD. So our approach to the management medication side effect, first of all, medication discontinuous. Immediately stop medication for severe reaction and document for further treatment planning. Other thing, so after that, complication, we will manage the complication, promptly treat adverse effect with a specialist, consultation, minor effect handling, temporarily use it, suspend the medication for mild reaction, and explore alternative therapies. Collaboration, decision making, collaboration with patient on treatment choice, consider individualized risk factors. Ongoing monitoring, also conduct regular surveillance of disease activities and potential adverse effect. In summary, we have the balancing between efficacy and safety in the rheumatoid arthritis treatment. First of all, we are started with assessment, evaluated the disease activity, comorbidity, and patient preference. Also, the selection chose appropriate therapy use based on risk-benefit profile, monitoring, regular lab test, and clinical evaluation, adjustment, modified treatment if inadequate response or adverse effect has been developed. So future direction and conclusion, we think we will have the precision medicine in the futures. That's biomarker help they predict which treatment will be work best for the specific patient. Another thing, shared decision making, patient and health providers choose the treatment together based on values and preference. And new therapy, novel medication target different immune pathway with improved the safety profile. the RA treatment landscape continues to evolve. So balancing efficacy and safety remain the cornerstone for optimal care for rheumatoid arthritis. So by this slide, I will say thank you for all. You borrowed me your hearing for last 10 minutes. And I want my message for this is understanding the efficacy and safety balance is the crucial for optimal RA treatment outcome. Please feel free for any question. Thank you.
Allah يعطيك العافية دكتور ماجد. Let's move to the last speaker we have for today's session. It's a pleasure to introduce Dr. Hani Sultan, a dedicated cardiology clinical pharmacist, currently serving at the Armed Forces Hospital. Certified in cardiology clinical pharmacy, reflecting his commitment to advancing pharmaceutical care in cardiology. Warmly welcome Dr. Sultan.
يا حائل المجد مجدي أن أكون هنا أنيخ قلبي في سلم الهوى وأجا. So first of all, I have no relevant financial or non-financial conflict of interest to be disclosed. Let us go back in a history 20 years ago, exactly at 2005, to image one day of life for the undiagnosed and treated urea cycle disorder patient, have a history of the recurrent admission to ER due to recurrent seizure, convulsion, irritability, severe vomiting, poor feeding, brain edema, and may eventually death. Then, at a moment, the game have been changed. At 2005 and 2013, and from this date, the sun still comes up. So, urea cycle disorder is defined as inherited disease that affect how the body remove the waste and is made from the breaking down of the protein. In a healthy person, the liver makes several enzymes is essential to change nitrogen into urea, which is then removed from the body in urine, and this process is called urea cycle. The liver in a person with urea cycle disorder is a missing enzyme necessary to convert nitrogen into urea, and as a result, ammonia, which is a highly toxic and a highly toxic substance, built up in the bloodstream and is not removed from the body. If it's still untreated, the high amount of the ammonia can cause brain damage, coma, and eventually death. So this is a urea cycle, which is metabolic pathway that transform nitrogen into urea for the excretion of the body. Any deficiency, if any one of this enzyme in this metabolic pathway, result in the diagnosis of the urea cycle disorder. Urea cycle defect incidence globally approximately 1 in 30,000 newborn patient, considered as a genetic autosomal recessive gene disorder associated with hyperammonemia, which is a common presentation for the defect. So urea cycle disorders, group of the defects named based on the initially of the missing enzyme. Deficiency in any one of this enzyme or transporter typically result in hyperammonemia with a variable clinical presentation depending on the severity of the mutation and the residual enzyme activity. Regarding the diagnosis of the urea cycle disorder, the age of onset and the specific symptoms vary between the different type of the urea cycle disorder based on the missed enzyme, and this disorder is most often diagnosed in infancy, but some children do not show symptoms until early childhood. In those patients with a severe urea cycle disorder, the symptoms will develop within the first 24 hours of life. The baby will become very sleepy, irritable, and will have feeding problems, including poor feeding, vomiting, and regarding the neurologic manifestations such as a seizure, trouble breathing, and a coma may appear later, and these neurologic abnormalities and impaired cognitive function are significantly correlated with duration of the elevated of the ammonia level in the blood and encephalopathy. Thus, normalization of the ammonia level considered as a management priority. Regarding the management and the treatment for the urea cycle disorder, so once the patient brings to the ER with a suspected urea cycle disorder with suspected symptoms of this diagnosis such as severe vomiting, lethargy, coma, elevated plasma, ammonia, respiratory alkalosis, recommended to administer of the nitrogen scavenger to reduce the ammonia level in the bloodstream, either with a sodium benzoate, sodium phenyl acetate, or sodium phenyl butyrate, with consideration of the amino acid such as arginine and citrulline supplementation, in addition to the order of the laboratory workup to monitor response of the highly elevated ammonia to the initial management. We can consider dialysis based on the highly level of the ammonia. Then once the patient stabilized, switch it to the long-term management through controlling of the protein diet, chronic and long-term management of the oral form for the medications to consider as a chronic scavenger therapy, arginine citrulline supplementation with regular monitoring, and consideration of the liver transplant as a last option treatment for this patient with a recurrent event of the UCD hyperammonemic crisis. So regarding pharmacotherapy for the urea cycle disorder, the pharmacologic therapy of the hyperammonemia consists of administration of the combination preparation of the sodium phenyl acetate with sodium benzoate. Most of patients are given also arginine, whereas citrulline and carglumic acid used in only few cases of the UCDs based on the missed enzyme inducing of UCD. Intravenous infusion of the sodium benzoate with sodium phenyl butyrate approved in FDA at 2005 for the IV infusion. The effect of this treatment with intravenous infusion on the survival in patients with the UCD evaluated in 25 years of the non-randomized, uncontrolled open-label study at 118 hospitals, including around 300 of the patients, with overall survival was 84. Intravenous arginine amino acid supplement used as a part of the initial management for the metabolic decompensation in all forms of UCDs except arginine deficiency, citrulline indicated for the OTC and CPSI deficiency. And then once the intravenous amino acid supplementation discontinue and the intravenous infusion of the sodium phenyl acetate and sodium benzoate, then the patient will be switched to the oral either glycerol phenyl butyrate or sodium phenyl butyrate, which are available as oral medication for the UCD management indicated as a long-term pharmacotherapeutics. Knowing that oral glycerol phenyl butyrate act as slow release form of the sodium phenyl butyrate, achieving more stable control of the ammonia level over a 24-hour period. In addition, it may offer advantage with regard to the tolerability and palatability, since it is a colorless and tasteless oil with no sodium content. However, its use is contraindicated in infants and under 2 months of age due to immature pancreatic exocrine function that could lead to insufficient drug metabolism. So this is recommendation by the American College of the Medicinal Genetics and European Society for the Pediatric Gastroenterology, Hepatology and Nutrition. They are recommended use of the sodium benzoate for the acute hyperammonemia, but they have been given less preference for the sodium benzoate for the long-term management due to lower efficacy, while they are recommending use of the glyceryl phenyl butyrate for the chronic ammonia level as a long-term management in UCD patient due to superior nitrogen scavenging and patient compliance. The UCD consortium guideline recommend to combine both of agent either in the acute or in the chronic management setting in case there is no response for the single agent. So glyceryl phenyl butyrate is approved in the US and European 2013 for management of patients with a urea cycle disorder who cannot be managed by the dietary protein restriction or amino acid supplement, and this approval were based on the individual pooled result from 5 short-term studies and 3 long-term follow-on and pooled study result. So the preferred agent for the long-term management by the guideline is glycerol phenyl butyrate. Glyceryl phenyl butyrate for the maintenance of a treatment of patient with deficiencies in enzyme of the urea cycle is a title for the expert opinion paper released at 2017 to evaluate efficacy and demonstrate safety of the glycerol phenyl butyrate compared to the traditional therapies such as sodium phenyl butyrate. So the figure A showing that a clinically meaningful and statistically significant difference in favor of the glycerol phenyl butyrate versus sodium, which seen in controlling blood ammonia level among those who's completed the short-term studies as measured by area under the care for the 24-hour period. While figure B showing that similar results were seen in a mean short-term glutamine level, which were significantly lower after administration of the glycerol phenyl butyrate compared with sodium, because increasing in the glutamine level leading to astrocyte swelling, brain edema, intracranial pressure, and lead ultimately to brain damage and death. In this figure, the long-term mean ammonia level, the previous slide was for the short-term management over 24 hours. This figure explains that the ammonia level will be controlled for the 12 months as a long-term management for both pedia and adult patient. In this figure, as a result for this long-term normalization of the ammonia level, this figure showing that the rate of the hyperammonemic crisis per patient decreased while on the glyceryl phenyl butyrate versus pre-enrollment. Overall patient pre-enrollment had average of 0.58 event per patient per year, while they were on the sodium phenyl butyrate, and after switching to the glycerol phenyl butyrate, the patient experienced average of 0.2 event per patient per year. Overall, regarding the number of symptoms per patient, around 70% of patients reported at least one symptoms commonly associated with a nitrogen scavenging medication at baseline, while they were on the sodium phenyl butyrate. And the mean number of symptoms per patient approximately 2.5 for all patient group, while on the sodium phenyl butyrate, and significantly reduced in each category group, either pediatric or adult group, while they were on the glycerol phenyl butyrate treatment over 3 months. Then after 3 months of treatment with GPB, the proportion of patients with no symptoms, with no urea cycle disorder symptoms increased from 31 to 53 for all patient groups, and from 30.6 to 47 for the pediatric patient. So in conclusion, they have been concluded that glycerol phenyl butyrate is a better tolerated than sodium phenyl butyrate and enable patients with urea cycle disorder to reach ammonia and glutamine target. The maintenance target of the ammonia level allows better long-term control, so it is recommended and preferred as a long-term management strategy in patients with urea cycle defect with reduced neurological sequelae. This is recommended dosage and administration. It's contraindicated in case of the hypersensitivity or in those patients less than 2 months of age. The most common adverse reaction.
Thank you for all esteemed doctors. Kindly asking you to join me to the stage to open the floor for any doctors. Kindly asking you to join me to the stage to open the floor for any comments or questions. We will open the floor for 10 minutes if you have any question. I will start the discussion I have a question for Dr. Majid. When it comes for term biologic use for RA patient, what are the latest safety considerations we need to keep in mind? Okay. When it comes to the long-term biologics for RA patients, what are the latest safety considerations? Yeah.
The long-term?
Yeah, the long-term biologic use for RA patients. يعني إذا استخدمنا البيولوجيكس for a patient for a long term. What we should keep in mind when it comes to the safety?
So for the safety, we're monitoring the patient for the usual side effect, especially the infection, reactivation of any infection, other thing for the liver toxicity for some biological treatment, and cardiovascular activities, adverse effect. Also, some patients, they will develop the intolerance of medication or failures of medication as primary failures or secondary failures.
Yeah. Okay. Thank you, Dr. Majid. Any question? أنا ما أتوقع أن البيولوجيكس ما فيه controversial هذه الاريا. طيب, let me ask Dr. Maram for the IBD and early intervention with the IBD patients. What are the latest treatment paradigm for early intervention for the IBD patients?
Thank you, Dr. for your question. So usually the intervention based on, as I discussed earlier in the presentation, based on the severity. However, early intervention either with conventional or biologics is highly recommended. And eventually those patients who are unconventional, they will use biologics. So also early starting biologics is highly recommended to prevent the complication with those patients. But unfortunately, based from my short experience here in Ha'il region, usually during patient review, I found most of the patients, they discover the disease like in late stage. Even they have sign symptoms, however, they don't seek any medical attention unless it's severe and they notice rectal bleeding or severe GI pain. For regular symptoms such as colic, pain, or diarrhea, they don't see medical attention unless it's severe. So unfortunately, most of our patients, they were severe. We have few patients considered as a mild to moderate. Usually, most of our patients that we reviewed, they were on biologics. Thank you, Doctor.
Thank you. Do you have any questions, any comments before we conclude? Keep in the comments.
Nothing. لا بس احنا كاوتكم احنا looking في الاي في دي على البروجريسيف اوف ذا ديزيز الريميشن هذه كلها يس هذه الاشياء اللي نقدر نقول انه البيشنت اوريدي از ريسبونس تو ذا biologics or not response. حتى يعني later on لما انا اجي أنا طبعاً أحب أفترس الشركات. آخر شيء لما أنا أجي أقول إنه هذا البرودكت هذا أو البيولوجيك هذا تشيف التارجت تبعي، هل هو مثلاً completely مثلاً improve الريميشن ولا لا؟ هذه الأشياء كلها we looking عليها. فإحنا عندنا تقريباً 4 outcomes we looking عليها في البيشنت الIBD patient أو الألسريتيف with الألسريتيف colitis and Crohn's disease. أوكي كل واحد فيهم صح في تشابه في التريتمنت بس البروجريسز حقت الديزيز آخر شيء لما أنا أجي بدي أختار مثلا الأوباداسيتينيب أنا مع الألسريتيف is given a good result بصراحة comparing لا حينبسطوا اوكي يعني لا انا ما قاعده اقول لك انا اعتبر شوف الأوباداسيتينيب انا اعتبر هو الفيوتشر اوف ذا تريتمنت للاوتوميون ديزيز ما حدا ينافس في هذا البرودكت بصراحه من ناحيه اللونج تيرم افيكاسي من ناحيه everything انا اعتبره ماجيك لايك الهيدروكورتيزون ماجيك ميديكيشن. خلاص لا تسأليني كذا أي شيء سؤال ثاني لا أروح أرجع ثاني.
IBD it's already under the radar in MOH. الله يعطيكم العافية. Let's conclude this discussion. Thank you all for being here. الله يعطيكم العافية. We have a question.
Thank you, Dr. Majid, for your nice presentation. My question is, as you know, we targeting for patient with rheumatoid arthritis and achieve remission. Once the patient achieve a remission, what is your experience in tapering down biologic? Is there any relapse or a flare after you tapering, or you have any experience you can share with us?
Thank you, Doctor, for this value questions. So usually we don't let the patient stable all the times. When the patient is stable on medication for more than 6 to 1 years, we will start to tapering dose the medication or spacing medication. Some of medication they are taken at every month or every 2 weeks. We space between the medication and monitoring the patient. So we are against disruptly stopping of medication.
I'm sorry, but one more question to Dr. Khalida. You said baricitinib is the future of the treatment. Al-obadasitinib. What makes the obadasitinib different from other medications such as tofacitinib and obada?
احنا بنقول بالجاك انهبيتورز في واحد مش راضي والدين في المجموعه هذه هو اللي جاب السمعه السيئه للجاك انهبيتورز. الجاك انهبيتورز از جود برودكتس كل الميديكيشن اللي فيه اعطت يعني بصراحه في كل الاوتوميون ديزيز من الباريسيتينب للاباريسيتينب للتوفاسيتينب يعني كلنا شفنا على اختلاف الديزيز اريا اتشيفمنت رائع جدا. اوكي الامبروفمنت او في الريميشن كانت جدا عاليه سواء في البيشنت خاصه يعني انا بقعد اقول لك اياها مثلا في الار اي. اوكي الأوباداسيتينب في الريسك ريشيو اوكي لما اجي انا ارجع اشوفها ترى على فكره الهيوميرا اعلى منه مثلا بالليفر كومبليكيشن او الليفر ديزيز او الانداك او الانديوزنج في الانزيم. اوكي لما تيجي تشوف الريسك ريشيو تبعته لما تيجي تشوف الاذر كومبليكيشن كديفيتي او فينوس ثرومبو امبوليزم برضو ترى على فكره هذه احنا مع 1 ميديكيشن من نفس الكلاس واتوقع انه قلبت اي ثينك هو
سيتينب اجلوستوسبكتينب او حاجه زي كده is not marketing here. حتى يعني in the Gulf is not marketing here. هو اللي كانت اكثر الكيسز عليه. وذن التوفاسيتينب. اوكي حتى الريال وورد داتا ايفيدنس كانت كلها حتى الاف دي اي الوارنينج كلها كانت علشان التوفاسيتينب والانسيدنس اوف ذا ميجر كارديوفاسكولار ديزيز الفي تي اي. هذه الاشياء كانت اسوشيتد اكثر مع هذول التو ميديكيشنز فروم ذا جاك انهبيتورز. لكن ان ذا فيوتشر احنا وي لوكينج على الجاك انهبيتورز كل ما كان سلكتيف اكثر كل ما كان احنا عندنا قاعدين ننتقي مولكيول اكثر افضل ومور سيف والافيكاسي تبعته عاليه جدا. انا الأوباداسيتينب بسبب الديفرنت ديزيز ارياز كفرنج يعني انا اعتبر سوري السوريتك ارثرايتس اوكي احنا كثيرد لاين عم نستخدمه. الار اي انا اعتبره الفيرست لاين الحين حاليا خاصه بعد البيشنت was filled with the systemic treatment. عندنا البيشنت with the ulcerative colitis الأوباداسيتينب بصراحه هو الماجيك سوليوشن بصراحه بالنسبه للبيشنت خاصه اللي يكون عندهم باترميشن بليدنج الامور هذه البيشنت اذا دخل في undergo to the surgery كلها هذه يعني الأوباداسيتينب فعلا عمل لنا مينيمايز لهذه الكومبليكيشنز. اوكي يا بعدين هو من 15 to the 30 ملي جرامز ممكن في الهاي دوز انا اخذ 45 ملي جرامز. انا ما بعمل دعايه والله لابي ويا ويلهم لو يجوني بس انه فعلا انا احنا الاثنين زي الهيوميرا. انتم تذكروا الهيوميرا كيف دخل الماركت كيف عمل السحر كيف الناس كلها اعتبروا الهيوميرا هي الفيوتشر. الحين خلص الهيوميرا صار اللور افيكاسي بس في له افيكاسي لسه ستيل. مثلا احنا في السورايسز احنا على المدى ال 52 ويكس انا ممكن انا اوصل تو ذا الباسي 90 تو ذا 45% لسه ستيل في وي هاف يعني في بيشنت وذ البريجنانت بيشنت انا مضطره اني ارجع اخذ تي ان اف انهبيتورز في سم كونترا انديكيشن وي كانت اني انا اقدر اروح على الجاك على طول فيها سبيسيفيك كيسز.
There is any precaution or dose adjustment you recommend for such medication, especially the JAK inhibitor? You can share it with us.
Mostly كل الديزيز اريا في الاوتوميون ديزيز starting with 15 ملي جرام مثلا في الأوباداسيتينب then complete increase the dose to the 30 ملي جرام. انا ما شفت الى الان دوز ادجستمنت بالليفر ديزيز فقط هو الدوز ادجستمنت. ما ابغى افتي لك كل هذا لان انا زمان على البراكتس ترى على فكره صار لي سنتين صار لي سنتين actually with the project actually with the planning بعيده عن اني اشوف patient فاي لسه ستيل مستمره في وضع الجايد لاينز مع التيم الوزاره لاني كان فيما سبق اطلق علي كوين اوف بيولوجيك. اوكي فكنت احب البيولوجيك لان كنت احس اني كذا متميزه في الاريا حقت البيولوجيك. ف لسه ما في دوز ادجستمنت الا في الليفر ديزيز هي الاوباداسيتينب ونيدد. التوفاسيتينب احنا وي نيدد تو ادجست في لها كوشنز كثيره. التوفاسيتينب صراحه يعني انا من فروم كيسز شفتها كثير بيشنت مثلا في الاولوبيشيا توفاسيتينب كانت بدايه بتعمل ابنورماليتي بالاس جي على طول. البيشنت دخل اي سي يو بيشنت عمرها كان 22 سنه. ففي كثير كيسز انا شفتها في التوفاسيتينب. الاباريسيتينب او الباريسيتينب اللي دخلت كاولوبيشيا تريتمنت صراحه لسه سايد افكت عن التوفاسيتينب كومبيرنج مع التوفاسيتينب. الحين فايزر يزعلوا مني ويبغوا يهدروا دمي. اوكي
الله يعطيكم العافية. Thank you very much. Let's close this session. Thank you very much.
نشكر المتحدثين على إثرائهم ومعلوماتهم القيمة. أدعو الدكتور علي التبيناوي إلى المسرح لتكريم المتحدثين. الدكتورة سلطان
challenge yourself, show your skill, and most importantly, have a great time. Good luck for all participants.
ورحمة الله وبركاته. أسعد الله مساءكم جميعا. يحتاج ميكروفون ولا بدون؟ طيب. أسعد الله مساءكم جميعا سيداتي وسادتي أساتذتي وجميع الحضور الفضلاء. نحييكم في حضور هذه المسابقة الإكلينيكية المتميزة بين أفرقة على مستوى المنطقة، أفرقة أشاوس خبراء في العلاجيات. دعونا نرحب بالفريق الأول، فريق صيدلية مستشفى الولادة والأطفال. وعليكم السلام ورحمة الله وبركاته. عليكم السلام ورحمة الله وبركاته. شو متوترين؟ شوي. وضعك اوكي. بس ودي نتعرف عليكم لو سمحت. زميلنا الدكتور رحمن خشمان. الدكتور
سعود الدخيل.
الدكتورة
مها الرشيدي.
ونعم والله، حياكم الله جميعا. الآن دعونا نرحب بالفريق المنافس المغوار، فريق مستشفى الشمل العام. تفضلوا. وين أهل الشملي ما يصفقون ولا يتابعونا أونلاين؟ نتعرف عليكم. دكتور
مشعل الدومسي.
مشعل الدومسي. نعم والله. الدكتور
فرحان العنزي.
ونعم والله. الدكتور
نواف العنزي.
حياكم الله جميعا في هذه المسابقة، وإن شاء الله وضعكم أوكي. ما في أنا متوتر أكثر منكم، ما في يعني إن شاء الله ما في خسران معنا بإذن الله. دام دكتور أبو فارس موجود الأمور طيبة بإذن الله، الكل راح يطلع راضي. وحنا إن شاء الله فوق ما يعني نختبر قدراتكم، إنما هي مسابقة فقط يعني to brush up our knowledge in general. الشيء الثاني to have some fun، يعني نخرجكم من طور المحاضرات التعليمية إلى طور التعلم بالمتعة، دعنا نسميه كذلك. إن شاء الله كل شيء جاهز معكم. دكتور حمد لو سمحت بس تشيك على الآيباد الشباب. الآن بعطيك المختصر بس بدي أتأكد إنه شغال. طب بس بعطيهم الستريشن بسيط. المسابقة طبعا سوري الصوت عندي أنا جهوري عشان كذا. المسابقة طبعا هي 15 سؤال، كل سؤال مدته 40 ثانية. راح يظهر السؤال على السلايد الأيمن سوري، وراح يكون معكم 40 ثانية لقراءة السؤال وكذلك الإجابة. راح تظهر الخيارات هنا. طبعا المسابقة كما شرحت لكم سابقا هي تعتمد على المعلومات أولا وكذلك الوقت أولا، فمن يختار الإجابة الصحيحة سابقا أو أولا سوف يفوز بالجائزة أو سيتم احتساب النتيجة الصحيحة لصالحه. فلذلك الآن إذا أنتم مستعدين دكتور حمد.
مستعدين. إيه
شلون؟
إيه اتوقع ان التيم ليدر صار بالنص.
ما باكو شيء. معكم سليم. طيب اذا الكنترول جاهزين مستعدين لعرض الاسئله. والله اصارحكم شيء دكتور علي، قلبي يميل الى هذا الفريق لاني عملت معهم، وما راح يعني نقسم الجائزه ولكن يعني فيه اتفاق سري بين الدكتور ونعم فيكم وفيها. فكر مجرد دعابة فقط. ريدي إن شاء الله. يطلع السؤال 5 ثواني. نعم.
Okay, let's start with the first question. The left, sorry. You'll see the question here. Twenty-three seconds. 20 seconds. Minute. The answer: increase the dose of the levothyrox. Oh my God!
دعواتكم مبروكة لهم ما شاء الله على طول. يستاهلون فريق الشملي 742 نقطة. إذا مستعدين وضعكم مريح.
أيوة كذا أيوة تمام.
يلا the second question. Can we start the second question please?
The time starts. Seventeen minutes left. For second. 2. Screen for hepatitis B for treatment. Dr. Tariq, I think we need to change the schedule for Dr. Saud tomorrow. Put in the night duty. Okay. Next question.
الآن ننتقل للسؤال الثالث كنترول. وما زال فريق الشملي على الصدارة أو في الصدارة.
The time starts.
يلا مستشفى الولادة بسرعة. ما يصير.
20 seconds.
يبدو فريق الشملي واثقا من نفسه.
Clindamycin.
ألف مبروك وما زلتم في الصدارة ما شاء الله تبارك الله.
تستاهلون يا ابو سام. اوكي next question.
في مشاورات على عند فريق الشملي قوية.
Ten minutes left. Minotaur, the sign of the thromboembolism and endometrial cancer.
يعني ولا إجابة صح.
ما ضغط على الشاشة.
حدش جاوب. So nobody answered this question.
لا تصيرون.
So nobody answered this question. Next question.
جاوبت الشملي.
Nobody answered also. Next question.
لا يجاوبون ولا يذبحون المريض 70 سنة يا ابن الحلال.
We'll start with the medium level. Twenty-five seconds.
يا سلام.
Oh, the correct answer, huh?
نعم.
Oh.
مبروك. ما زال الشملي في الصدارة.
Next question. Question number 7. We'll start. Twenty-five seconds. Decrease in protein. Still nobody. Question number 8. Side effect.
بسرعة يا الشملي ما في وقت. والله محضرين كويس. أولنا الأسئلة معك. في طرق ثالث في شيء عندكم طبيعي ما شاء الله تبارك الله.
Okay, all the 2 team answer. Correct answer. Shamil. Okay, next question. Question number 9. Contraindication.
دكتورة مها ساعديهم شوي اضغطي.
Correct one, severe hepatic environment. Still. Shamli General Hospital.
ما شاء الله تستاهلون.
Okay, question number 10. Mechanism of action. Timer start. Correct answer, increase dopamine synthesis. والشامل General Hospital. Question number 11.
بدأت النهايات تتوضح.
So, so. Okay, next question. Question number 12.
قررتوا بهالسرعة؟ قررتوا خلاص ما شاء الله.
20 seconds. We'll see who's answered the correct answer. Pulmonary fibrosis. of. Okay. Next question. Easy left. Second. Serum creatinine greater than 1 point.
ما شاء الله. شدوا حيلكم شوي.
قربتوا ها؟ Next question. "25 minutes. Still الشملي. Last question. The last question.
محسومة يا دكتور حمد.
ها؟
محسومة.
والله. Everyone is put on. The last question.
خلاص.
Finished.
ألف مبروك لمستشفى الشملي.
مستشفى الشملي.
ألف مبروك والله تستاهلون، والله تستاهلون، ما قصرت والله بوجيهكم.